All right. I think I am now live on Facebook and YouTube at the same time. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. And here, hold on one sec. We're even going to go big. Ooh, I forgot to do one thing. Let's see here. See if I can bring this here. I don't know if this is going to work. Hello, hello. Okay. Oh, it is a cold Sunday here in California. Hello, YouTube. Hello, Facebook. Hello, my friends. Just getting started here. I think I've finally fixed the internet problems. So we're going to go big. Hold on a sec. Oh, nope. Hold on. Let's see here. Oh, the joys of technology. I'm just trying to fix one thing here. I thought I would get fancy. No. Oh, well. Oh, well, we'll save that for another day. Hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, September 28th, 2025, and it is time for another live IC support group meeting. Now, we have had a lot of technological problems. I am hoping now that we have fixed these. Hello. Hi, Gay. Hi, Peggy. Hi, Lori. I really need one of you guys to go on over to YouTube. Would you go to my YouTube channel, IC and Jill? And tell me if you have sound over there. Let me see here. Oh, it says I have sound. But if you could tell me if I have, for anybody over on YouTube, could you do me a favor and just write in the chat if we have sound or not? I am just not sure. Well, how you guys doing? So it is a cold day here in California. We were robbed of a summer. We've not had a normal summer, and everybody's sick. Everybody's got colds and stuff. So it's just kind of a weird time right now. So let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I do live support group meetings throughout the year, usually on our Facebook and our YouTube channel. My goal in doing these meetings is to educate, to inform, to help you know that there is hope, to give you comfort, to give you solid information, credibility tested, research backed information, because God knows if you come online, there's a lot of wacky stuff going on right now. There's a lot of people out there who are, they will say, hey, come sign up for my program for $1,000 and I'll teach you how to cure yourself. Well, I'm going to give you that information for free. That is my goal here, to give you this information for free, because guess what? I'm an IC patient too. Hi, Siri. What's the most effective treatment for IC? It depends upon what's driving. Whoop, there's my Siri. We just turned my Siri on my iPad. Here, hold on. So, Siri, frequency comes from the alpha afferent nerve in your bladder wall. So what that means then is that your bladder wall has been tweaked in some way. the nerves in your bladder wall have been irritated and or tweaked in some way. And so our job now is to try to figure out what could have been tweaking those nerves, because that's what's going to determine the best treatment for you. So with frequency, the first thing we want to consider is your bladder lining injured in some way? So, for example, I was working with a patient last week or about 10 days ago. I just started drinking Mountain Dew, and where she had estrogen atrophy, and she had no idea that when you are of a certain age, your bladder lining becomes weaker. And to put Mountain Dew on top of their very weak, fragile bladder lining is not a good idea. So concept number one is your bladder wall being irritated by a strong chemical? So we're thinking ketamine, we're thinking energy drinks, we're thinking chemotherapy, even some antibiotics can be quite irritating for the bladder wall. Oh, thank you, Gay. Really appreciate that. The second thing we want to ponder is the quality and health of your bladder wall with respect to estrogen atrophy if you're a woman. So if you are of a certain age, so if you're over the age of 45, then we're going to start looking at estrogen levels dropping. That's going to then make it much more difficult for your bladder to produce that nice, thick protective coating that normally protects those nerves. If you're on a strong birth control, if you're on Lupron for endometriosis, if you are on estrogen suppressors for breast cancer, those are all things that, surprising to so many of us, will absolutely affect the health of your bladder wall. The other thing that we're going to look at is there an outside influence? It could be compromising blood supply to the bladder, because if the bladder doesn't have good blood supply and the nerves don't have good blood supply, then they're going to become inflamed. So what's the very first thing we look for outside of the bladder? Tight pelvic floor muscles. Is there any chance that we're dealing with tight pelvic floor muscles? Hey, Kayleen, nice to see you, girl. Yeah, it has been a while. So tight pelvic floor muscles can certainly lead to frequency urgency. Hello, John, my friend John. How are you doing, dude? So, Suri, it begins with phenotype. We have to understand what your phenotype is first. Suri says, I was told my bladder is very distended and it feels like a basketball. That's not good. Suri, was there any event that you think triggered this for you? Was there something that you thought caused this in the first place? And also, Hun, how old are you? John, how are you feeling, Hun? Are you doing a little bit better? Anne says, I've been using topical estrogen. Now I'm getting burning. I don't know if it's from estrogen or a UTI. I've been using for over a month now. It was fine, but not now. Okay, so Anne, where's the burning? Is it on the inside? Is it in your urethra? Or is it in your bladder? Or is it on your vulva on the outside? That's going to help us figure this out for you. So where exactly is your burning? All right. So you guys, normally when I do these meetings, I have a little 30-minute intro, sometimes less, sometimes more. And then I will take your questions as long as you have questions. We're going to talk today a little bit about the urethra. Now, hold on a sec. I'm actually streaming both platforms from the same computer. We finally got near fiber, and so now I'm no longer having to look this way and this way. I'm actually able to look at one computer, which is very, very nice. Okay, so hold on. So let's go back to Suri here. Suri says, I've had IC since 2010. You didn't get diagnosed until your 2013. Okay, but Suri, still, is there any event that you associate with the onset of your symptoms? Like, had you had a baby? Was there a fall? Had you gone through chemotherapy? Were you under intense stress? What do you think? Was there anything that you thought could have triggered these symptoms for you? Thank you, Kayleen. Yeah, we're finally on a good speed. Anne says her burning feels like it's on the inside. Okay, inside where, Anne? Inside where? Inside urethra? Inside vagina? Okay, Suri said, nope, she didn't have a baby and no fall. But you had a lot of stress before your IC. A lot of us did have a lot of stress before the IC. So Suri says she was told that her bladder was very distended and it feels like a basketball. Suri, I'm assuming then that you've had a urodynamic cystoscopy. Have they? So, okay, Anne says her pain is inside of her vagina. So, Anne, that's probably estrogen atrophy. Okay, so Suri, the symptom you're having, okay, hold on one sec. So Suri says her bladder is very distended and it feels like a basketball, but her volume is only 300 cc's. Okay, so your bladder, even though it feels like it's distended, it's not distended, honey. 300 cc's is not a big bladder. If your bladder was at 1500 cc's, that would be a very big bladder. 300 cc's is what my urine capacity was the last time I had a cystoscopy. Okay, so Suri says she's had surgeries, hydrodistensions, DMSO, Elmeron, Miretric. Okay, so Suri did anything help? Did any of those therapies give you any relief or comfort? Any of them? Okay, she says she hasn't had a treatment or a surgery since 23. Okay, but of everything that you've done so far, hydrodistensions, DMSO bladder installations, Elmeron, Mirbatric, did anything make it better? No, only for a little while. So, Suri, the one thing you did not mention that is critically important for you to understand is actually the role of your pelvic floor muscles. So you got to understand 20, 30 years ago, we were all told we all have an incurable bladder disease. We were all given Elmeron. We were all given DMSO. I'm one of them, although I never actually took Elmeron because as a pharmacologist, it didn't make sense. But we were all told that we had an incurable bladder disease and that our future was going to be with bladder therapies. And yet, for the great majority of patients out there, when we did these bladder therapies, they didn't stop the flares. They didn't. You might have felt a little bit better for a brief period of time, but they didn't stop the flares. They kept coming back. For me, bladder therapies didn't do a damn thing for me. Never did. Never did. Oral therapies didn't do a damn thing for me either, other than chill me out, maybe reduce my stress a little bit. And then the research came out that talked about the role of the pelvic floor and how an injured tight pelvic floor muscle can absolutely cause bladder symptoms, frequency, urgency, pressure, pain. Tight pelvic floor muscles do that. In fact, we had a study last year that showed that, they were trying to prove where these symptoms came from. Like, are these urinary symptoms exclusively from the bladder or are they from everything else? And actually what that study found is that the symptoms of frequency, urgency are actually much more common in patients with tight pelvic floor muscles. So what our guidelines say very, very clearly is if you're not responding to therapy, if you're getting worse rather than better, we got to take a step back, revisit that diagnosis, and try to understand what could be causing this. What could they have missed? And you have not mentioned the single most important diagnostic test, which is the pelvic floor assessment. And Suri says here, well, how do I make the pelvic floor muscles less tight? Do I do Kegels? No, Absolutely not. The worst thing you can do with tight pelvic floor muscles is do a Kegel and make them tighter. And this is not something that you can guess about. You have to go to a physical therapist at least once to have a proper diagnostic assessment so that we know which muscles are the problem, if any. So what our national, our latest round of our American Urology Association guidelines for IC only have 2 recommendations. All the other treatments are options. There are only 2 written recommendations. Number 1, if a patient is suspected to have a Hunners lesion, for God's sake, look for them and treat them. And number 2, if a patient presents with tight pelvic floor muscles, you send them immediately to physical therapy. Immediately to physical therapy, because here's what we know. Physical therapy outperforms every other bladder treatment 2-to-1 in research studies. And we got the research to prove it. NIH funded, National Institutes of Health funded research helped us understand that physical therapy was far more effective than Elmeron and other bladder therapies. And think about what that means then, because again, all this time we were all told we had an incurable bladder disease, and you had doctors saying, we're sorry, that's all we can do. And then the pelvic floor physical therapy study comes out in which 70 to 75% of patients got substantially better. No other therapy got that good. This was not a little study guide. This was a multi-center federally funded study. The data in this is pristine. There's no influence in here at all. There's nobody who's going to make a profit from this. So you can really trust this data more than anything else. Okay, so when that study came out, I think it was in 2008, the entire IC world was put on its head because everybody went, oh, wait. How would physical therapy help a bladder disease? Maybe it's not just a bladder disease. Maybe for some of us, it's pelvic floor driven. And now we know with research that 85% of IC patients have tight pelvic floor muscles. 85. That's a massive, massive number of us. I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? For some of us, IC begins after a direct bladder injury, like going through chemotherapy, because the chemicals of chemo are very damaging to the bladder. Or let's just say you've had a really, really bad UTI. So the bladder wall gets injured, the bladder wall is screaming in pain, the pelvic floor gets tight to compensate for that pain. So our therapy for this patient is to try to identify what tweaked the bladder in the first place and address that. And we're going to hope that the pelvic floor is going to calm down. But that's the small subset. The much bigger subset of patients whose symptoms who begin with a pelvic floor trauma. Falling on their tailbone is a classic injury that we see. And that's how mine started. When I was 13, I fell and broke my tailbone into 2 pieces. I could move it around with my finger for about a year. It was ridiculous. So we're seeing lots of pelvic injuries now. If you were a football player, if you were a bike rider, if you fell downstairs, if you were in the service and you were a paratrooper, if you were a horseback rider, if you a motorcycle rider, anything at all like that, or if you were doing something that involved multiple traumas, like God forbid you be a cheerleader who was doing flying splits all the time, or a gymnast or an ice skater or an ice hockey player, that's absolutely going to tweak the pelvic floor. Okay. Kayleen, hold that thought, girl. Hold that thought. Suri said, I saw a therapist, which was very awkward because she would insert 2 fingers to see how strong I could pull with muscles. I went to for months and then that stopped. Okay, that's kind of weird. I don't understand what they were doing. So normally, let me get my model here. All right. And let me move this. I'm going to move that. All right. So let's talk about the pelvic floor real quick. Okay. Whoops. Oh, look, it's part of my levator got broken. Okay. So let us look at the pelvic floor for just one moment. So here's the front of your pelvis, right? So here's your pubic bone. Here's your hip bones. And if we turn around to the back, here's your spine with your spinal cord inside. Here's your sacrum, this triangular piece of bone. Here's your SI joints. Your SI joints attach your sacrum to your hip bone. With your tailbone. Now, the first thing I want you to do is I really want you to understand your tailbone a little bit more, because y'all see that tailbone is not just hanging there in the air. That tailbone is actually the functional center of your pelvic floor. You've got muscles that go up one side and muscles that go up the other side. So your pelvic floor is kind of a woven basket of muscles that hold everything in place and also help you move your body, right? So let's look at it from the inside now. From the inside now, here. I've got two separate windows open, so I keep looking at YouTube and then I keep looking at Facebook. Hi, Diane. All right. So, finger touching a pelvic floor, right? So normally your physical therapist is going to do internal massage. You see, look, there's a tailbone. See that right there? And they can use their finger to massage these muscles to get them to relax and release. Because guess what? When you fall all the time, you suffer basically a crush injury. You're crushing the muscles, you're crushing the nerves. And by the way here, we have somebody who's come into this support group meeting many times. She had not been able to sit down comfortably for years, like 25 years. She's been standing rather than sitting comfortably. And she kept telling her doctors, it's a nerve, something's happened. And the doctor said, no, it's IC, you need to do IC treatments. Okay. And of course, your bladder doesn't make it hard to sit down. You got to understand right now, if you have pain when you sit down that gets better when you stand up, that is not your bladder. That is clearly a muscle nerve issue. She finally had her surgery, and guess what? She had a massive nerve crush injury that they were able to restore. And it's just so exciting to be affirmed. You know, this is why you have to speak out. You have to talk about the symptoms you're having over and over and over again until you get somebody to listen. She finally got somebody to listen to what she was saying, that she had pain when she sat down, and they went, oh, we better look at these nerves. And they did indeed find a pudendal nerve crush injury. Okay, so getting back to this. So you see these holes back here in the sacrum? Nerves come out of that. The pudendal nerve will come out of those holes. And then the nerve will move into the pelvic cavity through the muscles to go where they need to go, down your leg and to innervate your structures here. What a lot of people don't understand is that you not only can you get a super tight muscle here, you can get a trigger point here, a muscle knot here. And when you have a muscle knot right here, right off of your tailbone, or God forbid, right around your vagina, or right around your testicles, or right around your urethra, now we've got a hard lump of muscle that cannot constrict and cannot relax. And that's going to hurt like heck. So when you see a physical therapist, the most important part of the physical therapy is that finger in your vagina or in your rectum if you're a gentleman. And this is what they do. They're looking for tender spots. They're looking for little lumps. They're looking for trigger points. And when they find them, they gently rub, normally the length of the muscle. You can see that. You see how I'm going the length of the muscle right here? Sometimes they will do what's called a strumming effect. Well, they will strum across the muscle. But it's all about trying to get these muscles relaxed and released and healthy again. It's very awkward because, you know, it would be so much easier if this were a leg injury or a shoulder injury or an arm injury. You know, it makes sense. If you hurt your arm and you get a muscle knot in it, it's like, oh God, it hurts. You go to the doctor, no big deal. You understand it's your arm. You know it hurts. When you move your arm, you know you have to have treatment in that muscle in your arm. God, the challenge is when you have a muscle injury inside your hip bones, inside your pelvic cavity, and it can cause all these symptoms of frequency, urgency, pressure, pain, which is very, very confusing. When you actually get that diagnosis that, hey, your muscles are really, really tight, you still have to work with the muscle, but you work with the muscle in a different way. You got to work with the muscle internally like this. And hopefully they will teach you how to do it so that you can do it yourself, so that you've got some independence here. Listen, I am the pelvic floor phenotype. When all the muscle research came out and I went and had a pelvic floor assessment, my muscles were like freaking concrete. There was no give to my muscles at all. No wonder sex was so painful. You know, and it all went back to this old tailbone injury. And now that I've gone through several rounds of physical therapy, now that I know what to do on my own, I can treat it. And also I can recognize when it's beginning in the first place and nip that sucker in the bud by trying to relax those muscles. So Suri says here, I have a lot of lower back pain on my left SI joint, and you get sciatica. So honey, there is the fact that you have sciatica is absolute proof that you have pelvic floor dysfunction. It's your piriformis muscle, and it could be your obturator muscle. So you need to be with a physical therapist, a properly trained pelvic floor physical therapist who will do a proper internal assessment and will do internal work. Okay, I got to say, man, I got into it this week. With somebody from the embedded UTI group. So, you know, if you've been online, you're going to inevitably, going into an IC group, find somebody who says, you have an embedded UTI. You need to be on antibiotics. And they imply that everybody has this embedded infection. I realize I've been dealing with this for well over 30 years. This is kind of it's not an old wives' tale. I mean, there are certainly some people who do have chronic infection, but it's a small group of patients. The great majority of patients do not have infection. And the great majority of patients do have tight pelvic floor muscles. You do. You do. There's no doubt about it. We got the research to back it up. And so we don't want you to do therapies that have no chance of helping you. And if bladder therapies are not working, maybe you need to go, these therapies have not helped me at all. If they do, maybe I feel better for a day or two after I have a rescue installation, but I'm still flaring like mad. Maybe we need to take a step back and see if we've missed anything. So anybody who says all or nothing, everybody has this or everybody has that, they're wrong. They're absolutely wrong. And it's proof that they've never worked with a large group of patients. The IC patient community is what we call heterogeneous. It means we're very different. For some people, IC begins in childhood. For others, it begins after menopause. For some, it begins during chemotherapy because the chemicals of the chemo damage their bladder. While for others, IC begins after they fall and break their tailbone. There is no infection happening in the broken tailbone patient. There is no infection happening in the chemotherapy patient. So I really, really, really want you guys to protect yourself when you're online. because there's misleading information out there. We have phenotypes now. We have distinct patient groups now. And if you go over to the IC Network website, I've got a free masterclass. Episode 4 goes over the phenotypes. And our goal is to try to figure out what your presentation is. So here, Suri has just given us a really giant clue. She's got left SI joint pain and she's got sciatica. Okay, hands down, pelvic floor, because that is a pelvic floor issue. Sue says, I hope your throat issue is cleared up. It's getting better. It's getting better. Okay, I'm going to come to Kayleen here real quick. So hold on one sec. Kayleen says, I think I have a UTI. I woke up in the middle of the night with an intense burning feeling. Urinating doesn't help since then, since the pain, burning frequency, and urgency hasn't stopped. You're having an adhesiolysis tomorrow, and the doctor said we can still do it. Well, it's really good that you're going to the doctor tomorrow, so let them do a urine test, see what they find, hon. Mindy says, my doctors believe that my IC manifested as a result of trauma to my bladder after having my C-section. Mindy, absolutely. Absolutely. And you would be what we would consider a surgical injury patient, and you're not the only one. This has happened before. And one of the reasons why they do, if anybody out there has had a hysterectomy, they must always do a hydrodistension with cystoscopy afterwards to make sure they didn't accidentally cut the bladder. Let's see here. Laura says, I'm getting better with physical therapy except loose bowels. I do have levator ani. Thank you for all you do. Yeah, excellent. I'm glad you're doing a little bit better. Thank you, Sue, for the 200 stars. Very, very, very much appreciated. And for you guys on YouTube, you got to stream again, right? I want to apologize for all the stream problems we've had with YouTube in the last 2 months. I think we figured it out this morning, as a matter of fact. Kayleen says here, does mobility disorder affect the pelvic floor? I guess with me being neurodivergent, I might have it. I think you have to explain mobility disorder a little bit more. I mean, if you have, what's the right word for it? Ehlers-Danlos, that causes hyperflexibility of joints like the SI joint, that certainly could affect the pelvic floor. Chris said, so you remember last week I said I was unsure why my pain increased and thought it was the chai tea. Well, the next day I went and did a urinalysis done and you had a bad UTI. It's so hard to tell what when it hurts all the time. I'm going through pelvic therapy and had to pause due to the infection. You know, infection's absolutely possible, girl. And chai tea is also very well known for triggering flares. So I'm really glad that you had both checked out. You know, when in doubt, always ask. If you believe you got an infection, ask your doctor to do a urine culture, or better yet, a next generation DNA urine test. Cara said, have I seen any correlation with IC and renal cell carcinoma? No. Not at all. It's very common for patients to feel like they've got cancer. I truly thought that I was dying of cancer when I was 32 and my bladder pain started for the first time. I was so obsessed with that idea that I demanded exploratory surgery. Because the pain of IC is rated equivalent to terminal cancer pain. Man, if you're having an agonizing flare, as I did my first year, you truly feel the pain that many people feel as they're dying. Bladder pain is characterized by being relentless and difficult to ignore. It's impossible to ignore it. Pounds away at you. It dominates your entire body and your entire psyche and consciousness. And so I was so convinced that I had cancer. I said, I want you to open me up. I do not believe you. I do not believe that I have a benign bladder disease. I believe that I'm dying. And my doctor said, really? And I went, oh, hell yeah. No regrets. I had it in September 1993. Dr. Bennett, my beloved gynecologist. And nope, no cancer. Now, one of the things that they can do very early on is what we call a urine cytology test. That's just a simple urine test. That just looks for your cancer markers, especially if you were a smoker or exposed to a lot of secondhand smoke. Smoking is the #1 cause of cancer, bladder cancer. But the other thing about bladder cancer that's important to know is that bladder cancer is considered one of the easiest to treat, but she's asking about kidney cancer. And I am not aware of any link between IC and kidney cancer. Now, I will say that I did attend, we had our international meeting of the national IC groups around the world, put together by a lovely lady named Matilda. And we had a fabulous guest speaker on ketamine cystitis, and ketamine cystitis is often used as a recreational drug, but it's also often used for pain care. 25 years ago, it was used for end-of-life care, but since then, ketamine has gotten very popular as kind of an easier way to address pain. But it's huge in the party circuit. And they had a young woman who became, when she was in high school, extremely addicted to ketamine. And finally, after a couple of years, she was able to go into rehab and get off of it. And she now has irreversible damage to her bladder. But the point that I'm trying to make here is ketamine also damages the kidneys. Sure, Kayleen, that would be fine. Cara says, I've had IC for 20 years and you were just diagnosed with kidney cancer. I have a rare type and I'm very young. Cara, honey, I'm so sorry. Wow. What, can you give us a name of it? I'd love to know more about that. And I'm just sending you like the biggest, most giant hug ever, ever, ever. You know, I had breast cancer last year, and cancer is just so endemic right now. It's amazing the number of cancer patients that are currently being diagnosed. Lots and lots of different types of cancer, but breast cancer, for example, is kind of at an epidemic level. I mean, it's stunning what's happening with cancer these days. You had chromophobe renal cell carcinoma. Huh. Let me go to the National Library of Medicine. And guys, we're still going to talk about the urethra. Just bear with me here. You always have good questions for me. It's a rare kidney cancer. It's often genetic. What are they going to do, hun? Looks like the prognosis is quite good. So are you going to do some chemo, or are they just going to take the kidney out? Is it in both kidneys or just one kidney? Christy said she got IC 101 in the mail. You're sending a check. You're very welcome, honey. Cara says it was found very early doing your IC imaging, so you're lucky. You had a total nephrectomy. Girl, how you doing? When was that? Was that this summer? Girl, you have been through it. Okay, so last week I talked about my my printing error with our IC flare guide, right? So we have the IC 101 book, which is kind of our flagship publication. It's the only book out there that talks about phenotypes. Yeah, nailed that early. So I've been rewriting the flare guide, and we thought we were done. We did a print run. I did it in a different way. I had somebody else helping, and it printed very, very poorly. The fonts, the font colors, everything. It's just yuck. I don't like it at all. And so I have a bunch of these that I'm pretty much just giving away. But I'm going to tell you right now, this is the new edited version. Half of it's done. This is the half that's remaining. I've changed it massively. I just, because we rewrote this like almost 3 months ago, and I'm like, I can make that a little bit better. I can make that a little bit better. So for those of you who got a free copy of this, just know the new one has a lot of changes in it. And I'm even going to add a couple more flares in it. I have it also significantly expanded. Thank you to my friend John, if you're still watching our discussion about sex flares, specifically how flares affect men and how flares affect women. So anyway, my other challenge with this is that it is exactly 10.1 ounces in envelope. Normally I would send this book rate. If it were under 10 ounces, I could just do the label here and send it out. Because it's 10.1 ounces, I have to take it to the post office and sign a form saying that there's nothing toxic in this. Because when you send media mail, people abuse that. So there are a lot of real specific rules. So if you have sent me an email wanting one of these challenging copies, these drafts, just know I've sent out probably 15 so far. But I probably have another 5 to send out, and I just haven't been able to get to the post office. And if anybody wants one of these, you can email me, icnetwork@mac.com. Email me your mailing address. You just have to understand that it printed poorly, and I'm extremely unhappy with it, but I don't just want to recycle these. There's still good information in it, provided you can just deal with, a missing comma here and a missing period here. But for the most part, I'm so angry at myself that I did that. I should not have done that, but I did. Normally we get a print review. We get a print. And I had the e-print for the e-document. What I did not have was the draft for the printed document. And when we actually went to print, it sucked. Okay, let us talk about the urethra, shall we? Do you know what your urethra is? The urethra is that little tube, or for men, a longer tube that goes from your bladder out of your body. Your urethra is a tube that drains urine. That little sucker, that little benign. So in a woman, your urethra is, a little bit less than the size of your little finger. For a man, it's 5 or 6 inches long. And you would think this little tiny tube would just be a piece of cake. It's not. When this little tube gets extremely irritated, it can hurt like the dickens. And it's very, very confusing for a patient. It's like, why is my urethra screaming? And the funny thing is sometimes, now I'm speaking for me personally, you can just be at work, driving in your car, and you get this stabbing sensation, this sharp prick in your urethra, and you go, what is that? It can be very quick, but it's very, very noticeable. And John says, yes, it can be extremely painful. And that is particularly true for men. So I wanted to talk a little bit about what triggers urethral pain and how you can deal with it. So Trigger number one for this little tube is putting anything in it. If you've been catheterized, if you're having a bladder installation or a test, anytime an instrument is put in your urethra, it is going to stretch your urethra. This is why they numb your urethra with a lidocaine gel first, to try to take some of the sting away. But it doesn't really hit you until you try to pee. The first time you pee afterwards, it's a nail biter. Diane, honey, I see them now. I've got 2 windows. My Facebook was overlapping my YouTube. So you hold that thought, honey, and I'm going to come back, okay? I promise I will come back and address your question. Okay. So the first couple of times, and especially the first time you try to pee after having anything put in your urethra, is fairly brutal. When I was a kid, I was getting urethral dilations. My urethra was very, very narrow because it was being squeezed by tight muscles. I developed a system to help me after I had my urethral dilations. What I would do, I learned early on that to try to sit on the toilet and dribble it out only perpetuates the pain. At least it only did for me. And so what I learned to do at the age of 13 was to drink a big glass of water. And when that water arrived in my bladder, I sat on the toilet, I bit my lip, and I just peed. I was just like, let it go. And you know what? That actually ended up working in the end. It did. It really helped me in the end. But just understand, we all have our own systems. It's quite normal for the urethra to scream the first couple of times you urinate after having anything put in it. The second thing that's going to tweak your urethra for women is estrogen atrophy. So the urethra is kind of the canary in the coal mine when it comes to estrogen levels. So how does the bladder and the urethra protect itself from the toxins in urine? Because urine is irritating. Urine contains ammonia and urea and all sorts of bad things. So how does that skin protect itself? Well, it does so with a really thick coating of mucus. So your bladder and your urethra are like your mouth. They're a hollow organ that's slippery on the inside. And that wetness, that mucus, is a physical barrier that pushes urine away from the cells. Okay? It's hydrophobic. It pushes urine away from the skin. So mucus health is everything. Your mucosal layer is everything. Unfortunately, mucus production is estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus. And you can get away with stuff. But ladies, if you're on an estrogen mimicker or an estrogen inhibitor because of breast cancer, if you're on Lupron for endo, if you're on birth control, even if you're 18 years old and on birth control, or you're just getting older, anytime estrogen levels drop, that mucosal layer thins, and guess what? The urethra is the first part of the urinary tract that often starts to scream at you. It feels like there's a drop of urine stuck in your urethra that won't come out. So this happened to me when I was 51 or 52. And guys, listen, my IC self-help skills are spot on. I know what the hell I'm doing here. So I had, for the first time, this persistent urethral discomfort, first time since I was a kid. But I knew I was peeing well because I had a good stream. I knew it was not a urethral stricture. So I threw everything I knew at this urethral pain. Nothing worked. And finally, 3 months in, I threw myself on the mercy of my my urologist, Dr. Klein. And I said, please help me. I do not understand what's happening with my urethra. First thing he did is he did a sonogram, and he goes, well, you're certainly emptying your bladder. There's no urine in your bladder. And then, got me up in the stirrups. So I visualized this. I'm laying on my back. My legs are in stirrups. He's sitting between my legs, and he is looking at my bits. And I'm kind of looking up at him through my knees. And he goes, Jill. I'm like, what? What? It's like, Jill, come on. And I'm like, what? What? He goes, didn't you use the estrogen cream I prescribed for you last year? and I very meekly said no. And he goes, why? And I said, because in my brain, I'm 25 years old and I cannot possibly have an age-related issue. Because that's truly how I feel. I was even looking in the mirror today, looking at my arms going, how the hell did that happen? It's like, wait, I'm 25 in here. Anyway, he explained that the urethra is canary in the coal mine when it comes to estrogen atrophy, and it's the first part of the urinary tract to start screaming. And so he re-prescribed the estrogen. Now, interestingly, I had an appointment with my gynecologist the next day. So I went to the gynecologist, and he looked and he agreed. He goes, yeah, girl, you're in severe estrogen atrophy here. You should have been using it. And so he confirmed what my urologist said. Okay, so if you are of a certain age and your skin is starting to get dry and you feel like there's a drop of urine stuck in your urethra that won't come out, very, very good chance that it's just estrogen atrophy. Okay, now here's a little anatomy lesson for you. So for a woman, so here's your urethra. Halfway up your urethra, on the outside of your urethra, is a little, it looks like a sea sponge. It's a little gland, and it's called the paraurethral gland. It's the female prostate gland. We have a prostate, just like a guy has a prostate. We have a prostate. Our prostate is very small compared to a male prostate. It doesn't cause benign prostatic hyperplasia like guys do, but guess what? It gets infected like male prostates can do. The problem with these glands is that once they get infected, the ducts that drain the gland usually get blocked. And so it becomes the equivalent of a deep pimple halfway up your urethra that hurts. And it's going to hurt the most if you try to have sex. So that sensation when you've got a deep pimple and it's like on a nerve and you touch and it hurts, but it's not even close to the surface of the skin. There's nothing you can do to drain it. That's exactly what these glands feel like. So if you have urethral pain at the moment of intercourse, or if the doctor is doing a pelvic exam, we want to look for an infected paraurethral gland. Now, you can figure that out yourself. Again, because remember, your urethra is very narrow, right? So you can, for a woman, actually using a very well-washed hand, ideally a glove, a little bit of KY, you can stick your finger just about an inch into your vagina, maybe 2, maybe an inch and a half at a most. Now, remember that your bladder and your urethra is in front of your vagina. So urethra, vagina, right? So we're going to put a finger here to touch here. So you can touch that gland yourself. And if it is tender to touch, then you want to get checked for that. Now, the challenge with this gland is draining it. I've worked with several patients who have had infected glands. And what's so interesting is when they actually drain it and culture it, it's not just one bacteria, it's a lot of different types of bacteria. It becomes this quite robust little infection right there in that gland. Sometimes to drain it, they have to, God, I wish I had, how can I demonstrate this? Okay, so let's say this is your urethra. Well, here. Okay, no, here. So here's your urethra coming down. They will have a finger in their vagina, in your vagina, pushing against the gland, and then they will either try to use their finger or something else to kind of squeeze it from the other side to try to get it to express fluid so that they can culture that fluid. So anyway, infected periurethral glands suck. The very first article I ever put on the IC Network website back in 1994 was an article about the female prostate gland. It was great. So anyway, okay, what's another thing that can trigger the urethra? Well, of course, tight pelvic floor muscles, my friend. If you've got super, super tight pelvic floor muscles, they wrap around the urethra. They're going to squeeze the urethra. They're going to give you a urethral stricture. So when you go to urinate, if you can pee like a horse, you're good. But if you're stopping and starting, and it takes time, seconds, to relax enough to release urine, that's a sign that we're dealing with some pretty tight pelvic floor muscles. So we want to look at that. Of course, infection. One of the great differences between a typical bladder wall flare and a UTI is most bladder wall flares don't cause urethral pain unless it's like an energy drink. Man, if you've been drinking energy drinks, everything's going to hurt down there. But bladder wall flares in general do not normally cause a lot of urethral pain, but UTIs often cause very, very severe urethral pain. So if you've got sudden urethral pain that's quite searing, we definitely want to do a home UTI test kit. If that comes back positive for nitrites and leukocytes, and absolutely call your doctor anyway and say, man, I do not know what's going on with my urethra here, but it's killing me. Let's make sure you don't have an infection. Severely acidic urine is going to potentially trigger irritation, and of course, strong chemical exposures like ketamine or chemotherapy. Those are also potentially going to tweak your tweak your urethra. So what are we going to do in a urethral flare? Number one, if you can, soak in a warm tub. A little bit of baking soda, maybe an Aveeno colloidal oatmeal soak that you can put in there. If we can just calm and soothe that skin on the outside, that can be quite comfortable. You could use some topical lidocaine cream. Lidocaine numbs the nerves. That's one way of trying to calm that urethra down. Some doctors like to make what we call a compounded cream. They make a compounded cream for vulvodynia and sometimes for urethral or rectal pain. So that compounded cream means it has a lot of different ingredients in it, kind of custom made for you. So sometimes they might put some ketamine in it. They might put some amitriptyline in it. They might put an antibiotic in it or a steroid in it, or even a muscle relaxant. So an Amibac cream, amitriptyline baclofen, is a very, very common compounded cream that is often given to patients who've got vulvodynia specifically, and sometimes that can be used around the urethra. And of course, if you're struggling with dryness, for God's sake, use your estrogen, because when you give this dry skin estrogen, it immediately plumps up and produces mucus. So when I use my topical estrogen, my number one target absolutely is my urethra area and then my vulva. I don't do a lot of internal vaginal estrogen at this point. I use it mostly externally. And then you can also use a vulva balm, which is an organic avocado, sea buckthorn, olive oil that is hydrophobic, that you can put around the entrance to your urethra and also on your vulva to just try to repel urine and get it off of that skin. Okay, so let us say that this urethral pain is happening like mine did, where mine lasted for 3 months. What are we going to do then? Well, this is when sometimes you're going to go with a more aggressive nerve calming techniques. I mean, of course, number one, we got to get the skin healthy. So again, for the estrogen atrophy patient, we're going to be doing some topical estrogen, which is what helped me the most. You could throw on some PEA, some palmitoyl ethanolamide, Peor, or P-leaf orally, because we know that calms nerves down, and there's a ton of research proving that. You could, of course, you should be doing pelvic floor physical therapy if your muscles are very tight. You know, for many, many years, I I have suffered off and on with rectal pain that I always thought was due to hemorrhoids. Okay. I mean, who doesn't? Pretty much everybody living has at one point in time had pain down there. But then once I started doing pelvic floor work and once I started doing my own work, I started noticing a trend. And that is at the first sign that I started having anal pain or rectal pain, I actually touched the muscles about an inch away from my rectum. And you know what? They were tight and tender to touch. And that's often my first sign that my pelvic floor muscles are unhappy with me, usually because I've been sitting too long working on IC network stuff. Judy on our websites in our shop. So you can kind of credibility test your urethral pain with that technique as well. So pelvic floor pain is achier, has a burning quality to it. The pain is worse after urination rather than before urination. And our number one symptom that muscles are getting funky is you just can't pee on command. You hesitate a couple of seconds before you can relax enough to release urine. So if you're having that in addition to your urethral pain, then maybe doing some internal pelvic floor work or starting to work with a physical therapist would be helpful. And of course, you can always go for any of the CBD products if you want. Just understand you can do CBD from hemp, which is legal in every state in the United States, or you can do CBD from medical marijuana if it's legal in your state. If you're going to go for a CBD topical or a CBD suppository, make sure that the company is providing testing results, because we know that medical marijuana CBD is often heavily contaminated with pesticides. And so that's the single most important thing you have to look for anytime you're considering medical marijuana. Look at the label, look at the brand, go to their website, see if they're testing. If they're not testing, I would go to another brand that is testing. The reason why I say that, and this was a shocking thing that happened in Southern California. There was a gentleman who I think had a very bad back injury. And he had been successfully using medical marijuana for that for many years. California kind of led the science. The medical marijuana pain relief research was done by University of California. Really good, strong, solid science. Absolutely science-based. So anyway, here's this gentleman who's used it very, very successfully. And then all of a sudden, he started getting sick. Substantially sick. And he said, I feel like I'm being poisoned. And so he was a smart guy. He thought, I wonder if it's a CBD. So he sent it off to a lab, and it was horrifically contaminated with pesticides. So he took it to a television station in Southern California and said, hey, this happened to me. I think it's happening to a lot of people. I think you should do a story on this. And that television show went one step further. What they did is they went to dispensaries across Southern California and bought a bunch of different brands and tested them all for contamination. And you know what? Most of them were contaminated with pesticides. It was amazing. And so once he was no longer exposed to the toxin, he was good. And that helps you understand that one of the big problems in the CBD industry is sourcing. As somebody who lives in California, we have obviously had for decades now criminal syndicates coming into our forests and planting medical marijuana. I mean, they've just up on the hillside. There was one right up on top of the hillside that burned, and I could see their solar. They had a solar power supply that would shine in the light, and I actually called the owner. I called the owner of the hillside and said, hey, you know, there's a truck up there where there's not supposed to be. And I think you got an illegal grow up there. And they did. The problem with the illegal grows is they just use a massive amount of pesticides and chemicals. And then the animals in the area die, they get very contaminated, and then the forestry goes in and looks for them. And when they find them, what they find is this catastrophe, environmental catastrophe, where it's done with massive herbicides and pesticides. So you don't want to swallow that. Kayleen said she stopped her gummies and she was still sick. Yeah, but Kayleen, it was a good experiment, girl. Judy says, can a prolapse push against a urethra and cause pain? Hell yeah, absolutely. Judy said, where can you purchase lidocaine? We have lidocaine in the IC Network shop. Fair warning, the over-the-counter lidocaine products also have a little alcohol in them. And so if you've got estrogen atrophy, use the vulva balm first. Use the vulva balm, then use your estrogen. Lori says, getting bladder installations weekly, getting catheterized twice during treatment, and nothing is offered as far as numbing. Lori, that's stunning to me. They are not doing a simple, I think they call it the Lidojet or the Eurojet. They're not numbing your urethra first. Ask for it. Man, that's outrageous. It's absolutely outrageous that they would not be doing that. All right, let's go to Diane, because Diane has been over on YouTube. Okay, and Diane, I'm sorry, honey. I'm scheduled for an InterStim trial on Wednesday. I've had 3 doctors recommend this going back 3 years. I know there are a lot of adverse events with the device in the MAUD database. The MAUD database is the FDA database that tracks side effects and adverse events from medical devices. And there are a ton of side effects reported to the FDA about InterStim. She says, I feel at this point I should give the trial a try because I've done everything else for frequency without enough relief, especially at night. And you've been most recently diagnosed with lesions. You had lesions treated with steroid shots 6 months ago, which helped with the pain a lot, but not the frequency. You've been doing the ankle stim PTNS for over a year, which helps some, but not enough, again, at night. My urologist said the InterStim will give me even more relief than the PTNS because it's constant stimulation. I've had pelvic floor therapy a couple of times in the last 3 years, and that helps then. But I think I have tight muscles at times because of the lesions, which are better because of the steroid shots, and you're taking the lactoferrin daily. Okay, Diane. So let's know what we're treating here. So physiologically, you have tight pelvic floor muscles and you have Hunners lesions, right? So is InterStim going to restore normal muscle tone? Some would argue maybe, and some would argue no. Is InterStim more effective than physical therapy at treating tight pelvic floor muscles? Oh, hell no. Because we have to understand why the muscles are tight in the first place, right? Are your muscles tight because of an injury? Are they tight because you got one leg longer than the other? Are they tight because you don't walk correctly? Are they tight because you were a victim of abuse? There is always going to be a structural reason why these muscles are tight, or maybe structural isn't the right word. We need to try to identify underlying cause as to why those muscles are tight. Does InterStim fix Hunners lesions? No, because Hunners lesions have now been connected to viral infections. So would neuromodulation fix a virus? No. Could neuromodulation help relax posterior fornix syndrome, which has been linked to lesion development? Maybe, but it doesn't fix a damaged ligament. That's a whole nother story. So InterStim is all about managing symptoms. It's not going to fix anything. It's just about managing symptoms. So, given the fact that InterStim technology has been refined tremendously, it's not unreasonable to consider it to see if it will help with frequency. I would not consider it unreasonable to have a trial. I think it's data. The other thing I think that would be really interesting would be an anesthetic cocktail. If they put lidocaine in your bladder, if that turns all your symptoms off, then we know your bladder wall is a source of lidocaine. It's a source of your frequency. If putting a lidocaine in your bladder does absolutely nothing, then we know that it's not your bladder wall driving your frequency. It's something else driving your frequency, like tight pelvic floor muscles. So having a trial is, I'm not opposed to that. Not that my opinion means anything to your medical decisioning. I like data. I like facts. It might be interesting to give it a shot. But number one, I would get in writing from your insurance company that it is covered by your insurance. I would not do it without proof in writing that it is covered, because far too many people are having it done only discovering after the fact that it's not covered. You can have urology staff, you can have hospital staff, even the insurance company itself might tell you over the phone that it's covered, only to discover afterwards, a week later, 2 weeks later, it was not covered. Now you got a $75,000 bill. So to protect yourself, I would get in writing your name, your medical record from your insurance company. This is covered. They will pay for it. The second thing I would want to know is, will they cover explants? So let's say you have it done and it doesn't work. So with the trial, they do an incision and they implant a lead down in your lower spine to deliver it to the post-tibial nerve or there's a sacral nerve. There are a couple of different places where they can put it. But it's surgery. It's implanted. So if it doesn't work, are they going to take it out, or are they going to keep it in there? You want to have it taken out. I would not agree to having it done if they don't also say in writing they will remove it if it doesn't work. When you do the trial, normally that'll be in your back for a week, 10 days, 2 weeks. You're going to do a voiding diary. I want you to do your voiding diary and be accurate. Don't exaggerate anything. Write down the times that you pee. In fact, start before you even have it done. You should have a couple of days where you've got a frequency journal so we know where you are. So let's just say you're peeing 30 times in 24 hours. And you've established that in the week before you have this, or in the day or two before you have this done. So do it tomorrow. Do it tomorrow and Tuesday. So we have a benchmark. Then after you have it done, do your voiding diary again. And now listen, if it goes from 30 to 20, that's a win. That's great. That means it's helping. But if it doesn't change your frequency level, then it's not working. And what I don't want is, I don't want you to feel pressured to go to the generator implant, or pressured by, that one of the things I'm very uncomfortable with this medical device is that the sales rep for the company is often in the OR and is often there and often involved in your care. And I'm very, very uncomfortable with that. I don't think somebody who gets paid for selling the device should be involved in your decision making and should be involved in your care that much. I think that they need to have medical professionals who are assisting with the implants, not somebody with a financial incentive. So I don't want you to feel pressured to have it completed because, hey, well, it's helped other patients. You just got to understand that there There's a financial incentive going on there too. I would also want you to go back to physical therapy. You said you have tight muscles, and you went to therapy a couple of times in the last 3 years. Girls, a couple of times isn't nothing. When you had your pelvic floor assessment, what did they find? Did you have tight muscles? If you did, you got to work it. We got to have, in some cases, intensive physical therapy, and you got to stick to it for a significant period of time. I mean, I've had 3 rounds of physical therapy in the last 10, 15 years. And because muscles are dynamic, we get them healthy for a couple of years, and then you take a road trip and you're in a car for 12 hours or 10 hours, and bam, the pelvic floor gets tight again. And now we got to work to get them relaxed again. So I am not convinced that you have done all the physical therapy you should do based upon what you're saying right there. I hope that makes sense. Sue says, my gynecologist said my vagina was like glass. Oh my God, before I got the estrogen cream. Yeah. And I bet the estrogen cream was not fun at first, right? Because when that skin is dry, it is hard to put anything on it. What did I do with my thingy? Oh, here it is. Anybody else are you wearing your fall gear? I got my flannel, pumpkins, and bonfire shirt on just to set the mood because I love fall. And I hope you've already got some of your Halloween decorations out. They're already happening here where we are. We already see those big giant skeletons up. I've got some of my Halloween decorations out. I just love the fall. Makes me happy. Trish says, I had surgery which altered my bladder shape, size, and location. The inside of my bladder looks fine, but I have intense bladder pain and spasms. They diagnosed me with IC, even though I have an MRI which shows that my pain is probably from scar tissue and a tethered bladder. So my question is, does this sound like IC to you? Oh, honey. Well, IC means you have frequency, urgency, pressure, pain, and they don't necessarily understand why. So IC is what we call a grab bag diagnosis. Okay. So you have some of the symptoms that are suggestive of IC. The question is, what is your phenotype? You had major bladder surgery. If your bladder shape, size, and location has changed, you had really significant surgery. And we have to ponder the effects of that surgery. We have to ponder the fact that you probably have intense pelvic floor dysfunction because of the pain of the surgery. You might have some neuroinflammation. You might have some scar tissue from that surgery pressing on nerves, constricting it. Trish, one of the things that happens to the bladder, if the bladder, this happened to a friend of mine, and you know what? Here, hold on, I got a picture. So, a good friend of mine I've talked about frequently was a gentleman who emailed me probably 8 or 9 years ago, and he was in very, very severe distress. He had prostate surgery that had been botched, just horrifically botched. And he ended up having like 7 or 8 or more surgeries to try to correct the damage done by the first surgeon who I think went to jail. This was kind of a medical malpractice situation. Quite a few patients were harmed, and he was one of them. So anyway, I connected him with a couple of the top doctors in the world, including one of the top doctors in IC. They went in and they fixed it. They tried to fix it all and yada, yada, yada. And then he went other places. Let's just say he, is a testimony to resilience on his part to keep going, but also the trauma of many surgeries over time. And with the last surgery, the second to last surgery that they did, they left a bleeder in his bladder. So they sent him home and his bladder filled with blood clots. Massive, massive blood clots. And then he couldn't pee. And it was an emergency. They go back to the ER. They take him right into the operating room. And literally, as they're opening him up, his bladder split in two. Just popped apart. It was, again, this is not you, but this was multiple traumas to the bladder. And so they had to sew it all back together. So they sewed his bladder wall back together. And then something very interesting happened. And this is a picture from his bladder. He got stones. We call these bladder stones that were emerging from the bladder itself. I don't know if you can see that these are sharp and bumpy, and they're stones. They're crystals. And that's what happens with very, very severe bladder wall injury, that it interferes with a calcium metabolism process, and the calcium has to go somewhere. And so the bladder just pushes it out as stones. So that's one example of weird things that can happen after you've had bladder surgery. Now, did that happen to you? No, I'm sure it didn't. But it's meaningful to understand that trauma kind of begets trauma. I think your guess of scar tissue is a really, really good guess. And also the tethered bladder, I would want to understand a lot more about that. So tethered bladder does not mean IC. Scar tissue does not mean IC. But the bladder pain and the spasms do. Have they looked inside your bladder? What do they see in your bladder now? Are there any wounds? Is there visible scar tissue, redness, inflammation? What do they see when they look in there? And Diane said that YouTube got really slow. Okay. All right, my friends on YouTube. Dottie says you're waiting for my son-in-law to put up your giant skeleton. No, I know. I almost bought one. I might buy one. We'll see. Trish said you also had a right nephrectomy. Girl, I mean, were you in an accident or something? What triggered these surgeries for you? Diane said, I think my muscles are tight because of the guarding effect. Yeah. Debbie Soros is having her innerstem removed tomorrow. Good job, girl. Diane had a test for Epstein-Barr, came back negative. I was working with a patient last week who had her Epstein-Barr test come back very, very aggressive and positive. So Epstein-Barr can infect the bladder. Diane said you had a pelvic exam and your muscles were fine. Good. You had a bladder instill and it didn't help. And Diane has a letter from the insurance saying it is deemed medically necessary. Good. Lisa, thank you for the 500 stars. Thank you, thank you, thank you. Debbie says they're removing mine tomorrow. However, we want to leave the wire in. That's odd. No. Well, I mean, that's a real, Debbie, that's a big point of debate. When you put a wire in the human body. The human body builds scar tissue around it. Your body is going to try to isolate this foreign invader and try to deal with it. It's not normal for there to be metal or any foreign material in the human body. So the human body basically kind of isolates it, for lack of a better term. So one of the things that happens with these interstim leads is that they just get enmeshed in a really thick layer of scar tissue, inflammation, whatever. And I'm trying to remember, I had one doctor describe to me that they basically had to try to chip away at the scar tissue to free the lead. And that chipping away at the scar tissue, right down in that area where it's a very, you got a lot of nerves down there. We don't want to just be chipping away at stuff. And so doctors got into the habit of just cutting the lead and leaving it in place. That's the easiest way to do it, but is that the best way to do it? I don't know. I think some doctors would say, yeah, because it does minimal trauma. Others doctors would say, no, we don't want to leave a foreign device in the body. I think I would approach it with, I want you to take as much of it as you can without hurting me. That's a reasonable approach to this. Just the longer you've had interstim in, the greater the likelihood that these leads are going to be very, very difficult to treat. I remember I was talking with a gentleman who was one of the original interstim patients like 25 years ago. And his device had stopped working decades ago, but he still had it in him and was contemplating having it removed. And it's like, why didn't you have it removed earlier? And he's like, I think he had moved away. I think if I remember correctly, he had it done in California, but he'd moved to Florida. I mean, I can remember the conversation. I totally remember that conversation. And he just didn't get it done. And basically waited way too long. And that's why I'm somewhat aggressive in telling patients to have a plan if it doesn't work, and talking to your doctor and talking to your insurance company about that plan. So if after 6 months you're not getting success from it, even if your trial was good, and so then you have the implant, 6 months later it's not working, for God's sake, get it out while you can. Don't sit on it for 10 years. It's going to be much harder to take out. Diane said they remove the trial either way. If it works or not, they will take it out in the office. And if it should be permanently implanted, that's in surgery the next day. Trish says she cannot handle the pain anymore. She's ready for a bladder augmentation. Okay. Trish, is it pain from lesions? Debbie said, I had to meet with the rep before the doctor agreed to remove. That made me very upset. Yeah, like, why is a rep in your decision-making process? And more importantly, did that rep try to encourage you to have another one put in? They get paid for every implant that goes in. Diane said, just my doctor and surgery. I won't feel pressured. If it doesn't reduce the frequency by 50%, I won't have it permanently implanted. I think that's reasonable. It's reasonable, and it says good on you, and will look good to your doctor, I think, for you to agree to have it done. But it also shows that you're being a very proactive, constructive patient by saying, here are my terms, here are my parameters, and this is what I will do, and this is what I will not do. Thank you, Diane, for your 20 stars. I appreciate it. Gay said she's already wearing her Halloween jewelry. What am I wearing right now? Oh, not quite yet. I'm still doing the pumpkin theme. Donna says, can you talk about the use of Botox for IC? I just finished bladder installations with minimal improvement. So, Donna, Botox, botulinum toxin, acts to temporarily numb nerves. It's used for a wide variety of medical conditions, including TMJ and migraines in your neck, anything where you've got a tight muscle and we're trying to get that muscle to release. Botox is certainly an option. Botox in the bladder wall has been used for many years. It was a step 5 treatment option in the last AUA guidelines from 2014. The reason why it was step 5 is because it has a very strong association with urinary retention. That, when they put the Botox into your bladder wall, they can accidentally numb the nerve that controls your ability to pee. And if they turn that nerve off, you will not be able to pee and you will need to self-cath. And I was working with a patient last week that happened to. And she was so angry. She said she will never do it again. She's having a very, very difficult time now emptying her bladder because of the Botox. So you have to understand that is a really significant risk of the bladder wall. Now, they moved it to step 4 because when they found that when they reduced the dose of it, it was not linked to as many episodes of urinary retention, but it certainly can happen. Worst case scenario is that it gets injected into an artery or a vein. I had one patient that happened to, and it stopped her heart. That's the only time that's ever happened in 30 years that I'm aware of. They got introduced into her bloodstream and it hit her heart. And I think she was in ICU for like 2 weeks. So it's not easy to do it in the bladder wall. A better place to do it is in the pelvic floor. When you're doing it in the pelvic floor, this is about relaxing tight pelvic floor muscles. So we're not running the risk of numbing the nerves that control your ability to urinate. So pelvic floor Botox, I think, is a little bit more appealing than bladder wall Botox. It is what it is. Brandon says, I swear finding anyone with experience with male IC is next to impossible, especially a man with urethral pain. Brandon, may I introduce you to John? John, may I introduce you to Brandon? John was in here earlier, John Musselman. Brandon, I work with a ton of men. Every week I work with men. And it's kind of one of my side specialties. I'm an IC support group leader and I'm an IC researcher, but my very first support group that I started 30 years ago was filled with men. And so I got very used to working with men from my earliest days. And John, by the way, I've got some email responses for you. I just haven't been able to get back to you, my friend. So we need to connect you together. Now, so Brandon, one of the reasons why men have urethral pain is because they have a trigger point in the pelvic floor muscles that are supporting the base of the penis. And I got the name of them right here. Hold on. This is one of the things. Hold on. Where did I put it? Oh, I'd already done it. Let's see. Hold on one sec. Let me find this here. I literally just hold on. I just got to find this. What chapter is it? Chapter 10. Okay. So, let me just read this to you a little bit more. There is no doubt that pain associated with sex, orgasm, ejaculation, and the penis are often very embarrassing to talk about, regardless of age. I once asked my father why men don't share that they are struggling with intimacy or urinary symptoms, even with their doctors. He answered bluntly, "Well, we don't talk about things that question our manhood." That, my male friends, is a very difficult obstacle to overcome. Yet, in any urology clinic, discomfort with intimacy is not only quite common, but there are genuine treatments that can help. Men with IC often report sharp burning or stabbing pain at the moment of orgasm and ejaculation. Each ejaculatory contraction can cause agonizing pain, often experienced the length of and to the tip of the urethra. Okay, hold on. Okay. So this is caused by tight bulbospongiosis and ischiocavernosus pelvic floor muscles, as well as trigger points in the muscle itself, right at the base of the penis, underneath in your belly, not in the penis. It's in your belly, your pelvic floor muscles. Because I mean, male anatomy is fascinating, and it's just so incredibly different from women. So treatment requires working directly with muscles, usually with a trained physical therapist, to restore normal tone and reduce pain. The challenge is that a significant number of physical therapists have not been trained to work with men. And anyway, we have an idea how to do that. So men often have palpable trigger points directly in the penis, which can be released with massage. However, this requires consultation with a professional. If you had pain with intimacy, it's important to use heat, like a hot shower or hot bath after sex. Some men will use a muscle relaxant or rectal Valium suppositories to relax the pelvic floor. And you can gently massage the bulbospongiosus and ischiocavernosus muscles, usually between the testicles and the length of the penis underneath the testicles. But you have to be very gentle, and you have to have a physical therapist teach you how to do it. And a physical therapist can help identify those trigger points. We don't have enough. Here, hold on. Where is it? Here it is. Okay. So there are 2 books, Brandon, that are stunningly helpful. Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss is the ultimate masterclass in all things pelvic floor, nerve, penile pain, et cetera, et cetera. This is the book that will explain exactly why and how muscle injuries can cause the symptoms of IC in men, as well as sexual and all that sort of stuff. This is my all-time favorite book. It is on sale right now, $10 off in the IC Network store, because Dr. Weiss just passed away this year, and we're doing it in honor of him for IC Awareness Month. So normally this book is, I think $36. And I think it's $26 in the IC Network store. Worth it. You can see if you look at mine, see all those highlights. This book has taught me more about the pelvic floor than anything else. And it is just a phenomenally good book. And it's got great pictures of male anatomy, and it will help you understand. Like, for example, this is a perfect picture that shows how a bicycle seat is going to push up against nerves and cause what we call cyclic syndrome. So this book is phenomenal. I recommend it to everybody. And there is a sale in the IC Network store right now. 2 more days. Use promo code IC Awareness, and you will get 10% off of your order on top of that. Okay. But the other book that is really fantastic for men is called Ending Male Pelvic Pain by Isa Herrera. And this was published over 10 years ago. But it is filled I mean, obviously, they're only using male pictures, anatomy for the most part, but this is just a great, great book on what you can do at home to try to get these muscles as healthy as possible, because we now believe that 90 to 95%, no, I got to get this right. Okay. 90% men diagnosed with chronic prostatitis, we now believe have tight pelvic floor muscles. And in my office, I'm going to say 95%. Like if you and I had a conversation, I can usually find that original pelvic injury through a discussion. Might be something you completely forgotten that we can directly link to all of this. Trish said, no one wants to operate. So Trish said, no one wants to operate on me anymore. You live on OxyContin. Your dynamics show a small bladder, of course, but your bladder looks beautiful. Okay, so Trish, there's good news there. Your bladder looks beautiful. Okay, that's good. So what that means is that this is being caused by something outside of your bladder, girl. I would be looking at endometriosis. I would be looking at pelvic congestion syndrome. I would be looking at your pelvic floor. I would be looking at your low back. If your bladder looks beautiful, like my bladder has always looked beautiful, despite the fact that I was peeing every 20, 30 minutes for a year. Now we know why, because for me, it was my muscles. So, I mean, that's good news. Celebrate that good news. Your bladder looks good. So now we look beyond the bladder. Debbie says she's having her interstim removed. She had it since January. She's having it removed because the battery pack hurts a great deal because you took a hard fall on it. Trish has a 9mm kidney stone. Girl, yikes. Trish has pain anytime my bladder starts to fill and pulls. So, Trish, we did have one patient who actually had a large kidney stone floating in her urine. She was afraid to let a doctor look in her bladder. And so for, 6, 7, 8 years, she had ever worsening IC pain. And finally, she let the doctor look, and they found a giant kidney stone floating in her urine that was scratching her bladder wall every time her bladder filled. And they broke it up, got it out, her bladder healed, and she's fine. Okay, John is still here. Excellent. Hey, Susan. Susan said, had my bladder removed on the 15th, still in the hospital. Girl! Big hug. Big, giant hug. Now, you guys, bladder removal is very, very rare. It's not, we would never do bladder removal for a pelvic floor patient. We would never do bladder removal for pudendal neuralgia. Bladder removal is only for a small group of patients, usually Hunners lesion patients who are not responding to therapy. So Susan did have her bladder removed. Surgery went well, but you're having complications due to a lack of knowledge by my former urologist and chronic UTIs yielding a candida infection. You also developed AFib. So now you're on blood thinners. Now you're on metoprolol to control the AFib, because I'm on metoprolol because a year ago I developed AFib for the first time after I had the COVID vaccine. And I'm not an anti-vaxxer, guys. Got to understand. I have had every vaccine out there but the current one. But what the research shows is the more vaccines you have, the greater the likelihood that it can affect your heart rhythm disorders. So I am done with COVID vaccines. Also too, Susan, I found that the blood thinner that they gave me, which I still have over in my bedroom, really upset my stomach. I think I lasted I was on for 6 months, and then I finally stopped because I didn't have any AFib. It only happened once. But I'm really sorry to hear that, honey. So nosocomial candida infections are often drug resistant. So how are you doing with the candida treatment? Angela says she is a grizzled veteran. Me too, girl. Recent personal discovery. I can no longer take arginine for my IC because it feeds Epstein-Barr in my system. Yes, it does. So arginine acts to enhance viral replication while lysine diminishes viral replication. So we talked a lot about that during COVID, that people with COVID would not normally be on anything that contains arginine. So if you were on a bladder supplement that had arginine, like Bladder Builder or Cystoman, you switched over to Cystoprotect, which I do not believe had arginine in it. So yeah, one of the things we learned a good 5 years ago. I'm glad you caught that. I mean, I have talked about that numerous times, especially with patients who have called on the phone. But we've talked about that in the live support group meetings too. And I know I've written articles about it at some point in time. Don't ask me when, but I know I have. Yeah, I know I did, because I probably in the COVID cystitis articles. Debbie said her generator hurt, interstim generator hurt when she exercised and if she wore spandex, but not too bad. Lisa, thank you for the 20 stars. So Lisa and Susan have both had their bladders removed this month. We have a really big bladder removal support forum over on the IC network. It was moderated for many years by one of our best volunteers, Carol. People don't use message boards really hardly at all anymore. So I've got this giant archive of really good information over there shared by patients you can search through, but I'm probably going to be deleting it at the end of the year. It costs $2,000 a year to maintain, and I'm just not going to pay that money. I just hate to do that. I feel like the only thing that's going to save our message boards is when people get completely sick of social media. I just do not feel like any of the social media groups are at this point in time particularly reliable. I feel like ours is because we talk about phenotypes. You can't, that's a fundamental problem here. The fundamental problem with online groups now is that you've got apples, oranges, and bananas in the group all talking to each other, thinking that they're helping each other. But a patient with severe Hunners lesions, as compared to a patient with pudendal neuralgia, they got nothing in common other than frequency urgency pain. And that experience of that Hunners lesion patient is going to scare the pudendal neuralgia patient, or vice versa. The other big issue with support groups is, and this was something that we caught on really early with our original group, IC Redwood Empire, way before the social media, is that newly diagnosed patients have very different needs than grizzled veterans. Newly diagnosed patients need information, they need hope, they need comfort and encouragement. The last thing they need to hear is the shocking story of somebody who's had their bladder removed, because that terrifies them. Grizzled veterans have to have a place where they get support. Newly diagnosed patients have to get their support in a different place where they can learn about phenotyping. And that's not to make anybody feel bad about having their bladder removed. That's real. That's real. But you need to be in a cystectomy support group now. Because there are people out there who've had this done who have good advice for you and good suggestions for you. And you can find that over in the IC Network forum, support forum. I just have very strong feelings right now about the state of the support groups online. I feel like they're doing a lot more harm than good. But then I think social media is doing a lot more harm than good. I feel like it's a source of poison in our lives now, to be quite honest. Susan said, there was a leak in the conduit where my ureter attached, and the yeast muck leaked into my abdomen. Girl, I'm in an awesome hospital with great care. 2 nephrectomy tubes were put in to bypass it until it heals. Awesome. Brandon says, have you ever taken Elmeron yourself? No, honey, I didn't. Because my second degree, I've got a degree in chemistry, and then I have a really rare degree in drug development pharmacology. And so when Elmeron, I was a support group leader in 1996 when it was approved. And I knew to look at bioavailability. So bioavailability means how much the medication reaches the area where it's supposed to help. And Elmeron is the equivalent of a chemical Band-Aid. It's just a Band-Aid. And so if you swallowed a Band-Aid, would you expect it to come out the other end a Band-Aid? And the answer is no, of course not. We have digestion. And the company, and it was not Janssen, it was a company who had it before Alza, Baker Norton. I think it was Baker Norton, who I think was the second owner of Elmeron. They did a bioavailability study and they published it. And that bioavailability study showed that 92% of Elmeron was destroyed by digestion. And at best, only 8% of it arrived in the bladder to do anything functional. Now, I've since had a couple of doctors say that they believe that it was actually 5%, that 95% was destroyed by digestion. I don't remember which doctor said that to me, but that was very specifically said to me. So you would have to take a lot of Elmeron over time for Elmeron to build up on the bladder wall because so much of it's destroyed by digestion. And of course, now we have the terrible legacy of that because Elmeron is now linked to retinal damage because it turns out we have a gag layer on our retinas, apparently. And more recently, inflammatory bowel disease. And with some patients developing very, very severe and aggressive dysplasia in their bowel that have led them to have their bowels removed, colectomy. And it was actually the eye researchers that made a more firm association. If you go back in time, and I have an article on this on our website, I've done articles showing every single case study and article that was published in medical journals on the role of Elmeron causing bowel issues. And there are numerous case studies and early papers that associated severe bowel conditions with Elmeron use, but more importantly, that when the patient stopped the Elmeron, the bowel generally healed in the great majority of patients. And I can still remember I had a gentleman call me who'd been on it for a year when he suddenly developed like explosive diarrhea. And what we were told is as support group leaders, and I don't know who told us this, is that somebody said to tell patients it was the capsule and to take it out of the capsule. And if you took it out of the capsule, the diarrhea would go away. Obviously, now we know that was completely wrong because we have all this data with inflammatory bowel disease and the medication itself. And it turns out that Elmeron, the structure of Elmeron is very, very similar to the structure of another medication that they use to damage the bowel for scientific studies. And we just had published this summer the first report of another medication, again, very similar to Elmeron, that has now been linked to inflammatory bowel disease. So I have an article on the IC Network website called The Tragic and Tarnished History of Elmiron. If you just go over to icnetwork.org, that has the timeline as revealed by the lawsuits that have been filed, along with an investigative report done by a publication called The Lever that was released last June that was really quite shocking. And it revealed kind of more details on how Elmiron was approved. That it turned out that it was invented in 1985. It was created, it was called an orphan drug in 1986. That then gave the company tax breaks. Didn't mean it worked, just gave the company tax breaks. Then like a year or two after that, it was made available on a compassionate use basis. And the compassionate use does not mean that there's any research showing it works or that it's safe. The FDA website said that very, very clearly. Compassionate use is designated for conditions where there are no other treatments. And so they were saying there were no other treatments for IC. So let's get this out on a compassionate use. And I've since worked with patients who got it on a compassionate use basis. And we have some of the original advertisements that went out through the ICA newsletter that encourage patients to go for it. So anyway, in 1991, the company made their first application for FDA approval. It was denied. The reason why it was denied is that only one doctor had success with it in the clinical trial. The FDA sent it back and said, we want more research because the data you're giving us shows that only one doctor, the guy who owns the patent, appears to have success. Every other doctor who was in your study had no success. The company balked. They didn't want to pay for another study, obviously. I mean, that has to be the only motivation. They resubmitted the data. It was denied again. Then they gave the FDA 5 years later some compassionate use data, and it was approved. Compassionate use data is not a formal study. It's just more anecdotal data. Hey, here's a few more patients that it helped. And for some, we don't know any of the details, but somehow it got approved. So it was in the wild for 18 years before that original study that the FDA asked for, a multi-center study without the patent holder, to see if it was actually effective. It took them 18 years to do it. It was led by Curtis Nickel, one of the top IC researchers in the world. He was up in Canada at Kingston Hospital, I think. And guess what? It didn't work. It didn't work. Only 20%, 22%, right around placebo, got a beneficial effect from it. For everybody else, it failed. And they thought, Curtis Nickel thought, that it would be pulled from the market literally the next day. But it's still out there. And now we have all this data that's linked this to retinal damage and blindness and now inflammatory bowel disease. So our thing for IC Awareness Month is we were trying to get patients to write their senators and congressmen to ask for a formal safety review, because I have doubts if this product should still be on the market. Now, what's crazy is over on Reddit, for example, I was presenting the data. I mean, this is not me making this up. These are published studies. I had somebody chew me out saying, how dare you say Elmiron doesn't work? It helped me. And, she's like, you're exaggerating this and making this much bigger than it is. And I presented the hard science back to her, but she's like, I don't believe you. And every patient should take Elmiron. And my answer was, no, every patient should not take Elmiron. We have phenotyping now. It all depends upon what your phenotype is. So anyway, if you've talked with patients who have gone blind and patients who have had their bowels removed, as I have many, many times, you look at this medication very, very differently. Diane says, I have been hearing about a neurostimulator that is implanted at the ankle that continually stimulates the tibial nerve. My uro said he was concerned that the implant would have more problems because of it being in the ankle and it could be bumped more. That's reasonable. That was all part of the original posterior post-tibial nerve stimulation protocol that I did in 1993 that was invented by Dr. Marshall Stoller at UC San Francisco. I still have tattoos. Let me see if I can. Oh, I don't know if you can see. I don't know if you can see that black mark right there. That is where That's where they put the needle in to do the ankle stem. Their goal from day one was to create a little implant that would do it. The advantage of doing it at the ankle is that you're not near the spinal cord and sacrum. Far fewer potential side effects with an ankle stem as compared to a sacral stem or a pudendal stem. And again, if we look at the FDA database, we can see thousands of adverse events with the inner stem as compared to probably less than 5 adverse events with the ankle stem. But I think your doctor has a very, very good point, and that is, would it be bumped down there? What I have seen is that it's a very, very small implant. And putting it in and taking it out is very, very easy. I mean, like literally, they can just use a local anesthetic, open up the skin, pull it out. So I think his point is very valid. But in the same sense, if I had to choose between being down by the pudendal nerve as compared to being at the ankle, I chose the ankle myself. Now, in the end, did ankle stem help me? Yeah, it broke me out of a horrific flare, but it didn't fix the underlying problem, which was tight pelvic floor muscles. I focused very, very entirely on muscles because those are one of my 2 phenotypes. Marlia says, you mentioned some antibiotics can possibly cause a flare. Are you familiar with antibiotics that it would be? Yes, Augmentin. Augmentin is notorious for irritating the bladder and causing a flare. I just did Keflex and I was fine, didn't irritate my bladder. And I've done amoxicillin a few times and that's never irritated my bladder. But I'll tell you, Augmentin kicked my bladder bad. A couple of times. I mean, we tried it. I can still remember that I'd taken it for like a day, maybe a day and a half. And I was just kind of a lunatic in pain. And I called the doctor and said, I can't take this. And he's like, okay, let's switch you to something else. Viviana says, what about doxycycline? I do not believe that the cyclines are associated with bladder irritation, but let's look it up. Here, hold on. Let me just go to doxycycline adverse events, and let's just see what they say. Let's see what the National Institutes of Health says. And this is from a 2023 article. Actually, this is from the National Library of Medicine. No. They gave me something else. This is an article from literally 10 days ago. So doxycycline is approved for treatment of Rocky Mountain spotted fever, tick-borne rickettsial fevers, chlamydia, uncomplicated UTI, cervical or rectal cancers caused by chlamydia, ureaplasma, recurring fever due to Lyme disease, mycoplasma, also used for cholera, plague, yikes, tularemia, which is rabbit fever. Ooh, tularemia is scary. along with Shigella, E. coli, Klebsiella. Okay. Let us see what these adverse events are. Diarrhea, photosensitivity, which is what happened to me when I took tetracycline as a kid, nausea, vomiting, skin rash, headaches, tooth discoloration, fixed drug eruption. And the more serious adverse events are leukopenia, anemia, throat irritation or trouble swallowing, chest pain, shortness of breath, irregular heart rates, painful urination. Okay, so it's not linked with frequency urgency, but it is linked with painful urination. Hold on. I'll give you the link for this too, so you can look at it yourself. Here, hun, let me just copy this link and I will put it, because this question came from Facebook, so I'm going to give you this link. Why is there a grr face next to me? I didn't do that. Who did that? I have no idea what that is. Hi, Les. Hi, Dottie. Oh, Dottie, I hope that you got your skelly up. Les says hello. Hello right back to you. I hope you're doing well. We are having a cold, cloudy day here in California. There is no sunshine to be had, which is why everything is so gray. Max says, wondering how you deal with general exhaustion fear of this being long-term. It's my 3-year anniversary of my first flare-up. And I'm feeling surprisingly emotional about it. Boy, what a great question. So here's the thing. Number one, and I say this to every patient, ISC is not life-threatening. It is not cancer. And often when I work with patients on the phone and I'm ending a conversation with them, I'm just very blunt in saying there's nothing about your case that worries me about your future. You're not peeing blood. There's no sign of a major infection. For many, if not most patients, we're dealing with injury, right? We're dealing with some sort of muscle or nerve injury. And just hearing that from somebody else, I think is very comforting, because the pain is so severe. Like I said earlier in the meeting, you really do feel at times like your life is under threat. It just turns out that the bladder organ pain is ridiculously painful, traumatizing pain to go through. But please understand that the old perception that IC is an incurable bladder disease is no longer the model that we use. IC is a pelvic pain syndrome for which there are many potential causes. Our job now is to try to identify your underlying cause and treat the underlying cause so that you're not symptomatic. So if you are a muscle injury patient, we're going to do muscle therapy. If you are a chemotherapy patient, we're going to give the bladder time to heal from the damage of the chemo, et cetera, et cetera. It's normal to have dark thoughts if you're in pain. We've all been there. My nephew had a heart attack on Friday, and he's young. And I was the one who I was able to get to the hospital very, very, very quickly. And I saw that look of fear in his eyes that I have had in my eyes. It's just scary. And he's fine. They fixed it. It's fine. Very, very mild. We're all good now. Everybody's good now. But when you're going through it, it's terrifying. That's normal. My job is to give you comfort, to give you hope, to give you context, to give you information, to give you new questions that you can ask your doctor, because I want to take the fear out of this. I want to say to you what nobody said to me, which is this is not your fault. You have done nothing wrong. There is no shame. There is no blame. You're hurt. Now we have to try to understand the injury a little bit more so we can treat the injury effectively. And again, it's a pelvic injury that lots of different things can be involved. Anything from a direct bladder wall injury from ketamine or chemotherapy, or even just drinking Mountain Dew or Diet Coke. That's going to injure the bladder wall. But we have a lot of patients who have fallen downstairs and developed IC. We've had, and we have a number of patients who were a victim of abuse when they were younger who have developed pelvic pain, things like that. But I want to say this. I woke up afraid this morning. I did. I woke up very anxious this morning. I have had anxiety most of my life because I was attacked as a child by somebody who became a rapist and murderer, and I lived in fear for many years. But it's been very, very controlled. Really very, very controlled until COVID hit. Man, COVID was scary. COVID was very, very scary, and the anxiety came back, but I know how to treat it. I have a system. I never let it get out of control. I know that the great challenge of having anxiety disorder is that you're constantly overdosing on adrenaline. And the adrenaline is driven by negative thoughts and catastrophizing and all sorts of stuff like that, which is a big part of anxiety. But honestly, we're at such I'm 65 years old. God, I don't even know how that happened. I have never, here in the United States, lived in such a stressful environment as our nation. I think that we are being bombarded by stress right now. And we all have to remember that as I say to many, many people, a lot of the conflict today is not really is political conflict. It's about companies deliberately keeping you angry so they can make money off of you. The social media e-commerce platform is designed specifically to generate conflict and anxiety. That's it. There are companies in Silicon Valley designed to create addiction. They want you to be on their platform all the time so that they can make money off of you. And TikTok is the worst example of it all, because they have now optimized the addictive response to short form video. And the thing is when you get on TikTok, you're not off of it for a good chunk of time, because it's all about brain chemistry. So think about it. We are being constantly fed stress and trauma. Constantly. And I think that's one reason why the world as a whole, the regular people, not the political elites, not all those people, they're living in their own world of stress and trauma, and they could care less what their decisions do to us. Those top leaders. I'm not being political here. I'm just saying the super rich don't care about the poor. They don't care about the effect of their decisions. I was working with a federal employee just on Friday who just doesn't even know if she's going to have a job next week. And she's terrified because she needs her health insurance. So I think we all have to turn it off. We have to step away. Like I'm now like being very attentive to what is going into my brain, what I am watching, what I am looking at, what I am listening to. I do not need to watch the news. I do not need to be on Twitter or any social media for any length of time. I use it now. I like on Twitter, the only place I go is Twitter, and I look at basically 3 accounts. That's it, and I'm done. I just do not want to give these billionaires another moment of my time, nor do they deserve my health. I'm not going to sacrifice my health to pay them money. I'm just not going to do it. So we're all having a lot of discussions about what were we doing 25 years ago before social media. We weren't all carrying phones, that's for sure. And we went outside and we talked to our neighbors and we went on hikes and we walked through the neighborhood and we went down to the bar and we had drinks with friends, and we were not being manipulated to the degree that we're all being manipulated right now. Max said, "Thank you, Jill. Interesting reflecting on anxiety and IC. I experienced both." So Max, let me be very, very specific about this. So we have phenotypes, right? So you got the Hunners lesion group, we got the bladder wall group, we got the pelvic floor group, we got the pudendal neuralgia group, and we have the widespread pain group. The widespread pain group, these are patients who have IC, IBS, vulvodynia, TMJ, fibro, migraines, whatever. If you've got 2 or more of those conditions, you are in chronic overlapping pain conditions or widespread pain. That is your phenotype. That is my second phenotype. So for example, I broke my tailbone, I had frequency urgency in junior high, I had vulvodynia in high school, I had severe IBS in my early 20s, migraines in my mid 20s, severe sensitivities and panic attacks in my late 20s, IC bladder pain in my early 30s. And when you're the patient, you're like, you might as well just be in a dryer being thrown around. It's like, what? How could I possibly have this pain condition and then that pain condition and then that pain condition and then that pain condition? I mean, I was watching my friends getting married and having babies. I was laying on my bathroom floor every morning with terrible IBS. And you just want to know why. I felt like I was being punished. I felt like I must have been a bad person. I was being punished in some way. None of it made sense. And guys, I was a presidential fellow in grad school. Listen, I'm a really good student. And yet I found no answers for this. And I was profoundly depressed. And I will say borderline suicidal. I didn't understand why I didn't have a normal life. But then a couple of things happened. The first thing talked about nerves. We learned that when the nerves in the bowel get irritated, the nerves in the bladder get irritated. And when the nerves in the bladder get irritated, the nerves in the bowel get irritated. They called that the pepperoni pizza algorithm. And that's like, oh, look at that. Nerves talk to each other. Didn't know that. And then we had another study that talked a little bit about genetics and how, in some cases, genetics can play a role in IC. I mean, my mother had symptoms. My sister had symptoms. My grandmother was diagnosed with IC at like 93. I had an aunt. I had a cousin, so now we got a little bit of a genetic connection. Well, Brandon, you're right. Brandon says social media has made this world more aggressive. Way, way more aggressive. It's shocking where we are right now. Okay, because people say things online they would never say in person. And that's the fundamental flaw with IC support groups, is that people say things in support groups they would never say in an in-person meeting. And let me tell you, when I had my live groups, we were very kind and respectful. We would have never said what people say in the online IC support groups to each other. And if they tried, I would shut them down in a heartbeat because I know how to run a meeting. Okay, so anyway, getting back to this whole anxiety, widespread pain thing. About 10 years ago, all the related pain groups got together and they funded a research team called the Chronic Pain Research Alliance. And their job was to try to figure out why some children go up to have widespread pain and others don't. I, for one, wanted to know. Why me? I wanted a normal life. I was supposed to have 5 children. And yet I was in horrific pain at times. They started studying the nervous system, because what's the connection between all those conditions? Nerves. So they studied the nerves in our skin, they studied the nerves in our spinal cord, and then they started studying the brain. And this is going to sound scary, but it's not scary, and there's a very happy ending. But here's what they found. Patients with widespread pain have brains that are behaving very, very abnormally. That 24 hours a day, 7 days a week, our brain behaves as if our life is at stake. Fight or flight is on all the time. So what is fight or flight? Fight or flight is controlled by your brainstem. Your brainstem is the most primitive part of your brain. It has one job: to save your life. There's no cognition happening in the brainstem at all. The brainstem does is monitors your sensory input to look for threats. What do you see? What do you hear? What do you smell? What do you taste? What are you touching? Do you hear somebody screaming? If you hear somebody screaming, your lower brain takes over and you go into fight or flight. 100%. Every time. If you see a saber-tooth tiger, you're going to go into fight or flight. If you read something online that's very scary, you're going to go into fight or flight. This is how the human body protects itself from predators and from threats. But normally, fight or flight is short term. Fight or flight would normally happen maybe for an hour, hour and a half, right? I mean, if you woke up, you saw a fire come into your house, of course you're going to go into fight or flight. Of course you're going to call 911. Of course the fire department's going to come out, and hopefully they're going to put out the fire. The fire is out an hour later, 2 hours later. The threat is gone. At that point in time, fight or flight is supposed to turn off. But it doesn't for some of us. For some of us, it stays on. How do we know you're in fight or flight? Hello, anxiety disorder. That's a clear sign that we've got a brain in fight or flight. So the question then is, why does this happen? Why does our central nervous system get habituated into fight or flight? And what the research shows is that for 80% of the children who develop widespread pain as an adult, there is a major physical injury. So I remember a couple years ago, like 2 years ago, I was working with a woman in her 50s who, when she was in high school, she broke her back. But her mom refused to take her to the doctor for 3 weeks, sent her to school with a broken back. And she was in agony, and her mom didn't believe her. Finally, they get her to the hospital, and x-rays prove it's a severe back injury. So that back injury, 14 days of pain, will put the brain into a constant state of fight or flight. So I've worked with a lot of patients who have had traumatic injuries in childhood. I worked with people who have been hit by cars, people who have fallen downstairs, a lot of young athletes. Physical trauma happens. Now, for the other 20%, it's a history of abuse or bullying, leaving the brain in a constant state of fight or flight. So the most common theme in my office is children who grow up in abusive or alcoholic homes. So I will never forget a woman I was talking with a couple years ago who had a very violent alcoholic father. And so she'd go to school, they'd, come home, and the anxiety started waiting for dad to come home. Then the anxiety really kicked in when dad came home and popped a beer and started drinking. Because they knew that he didn't just stop at one, he would drink and drink and drink until he was out of control and abusive. So she used to lock herself in the bathroom with her younger brother. I mean, she was in elementary school. She was a kid trying to save her life and to save her brother's life. So that they would lock themselves in the bathroom, and dad would break down the door and beat them up. drunk as a skunk. This went on for years in her life. So think about what that did to her brain. She lived in fight or flight every day of her childhood. You'd be stunned at how common this is. It's just stunningly common. Now, in my case, I grew up with a great family. I was never abused. I mean, my brother hit me once. We didn't yell. And my mother lived in a very, very verbally abusive home. My grandmother used to yell constantly all the time. And so my mom got out of that house when she was 16. She went into college at 16. She's a real smart girl. Never went back to live with her mom after that. And she felt very, very bad for leaving her younger sisters there, but she had to flee for her life. So when she met my dad, when she was 18 or 19 at UC Berkeley, she had one rule. There will be no yelling. If you want to be with me, there will be no yelling in our home. None. And my dad, not a problem. And I'm going to tell you right now, I can count on one hand the number of times I heard either my mother or my dad raise their voice. That's how traumatized my mother was by growing up in an abusive home. And the crazy thing is that when my grandmother was dying and in a nursing home in the last weeks of her, maybe the 6 months before she passed away, my mom went down and stayed down there for a couple of weeks with my aunt to try to help. My mom did not eat for 3 weeks because my grandmother was yelling again. And the trauma from that, my mother almost died. That when she came home, she was so ill, we had to take her to the emergency room. And they saved her life. She was no potassium. She had nothing. And the doctor literally said, and she would have been dead in an hour if you hadn't brought her in. That's how traumatic yelling in a home is. And the thing that I remember the most about that is that my mother was so scared because she was living in that childhood trauma again that she begged me to stay with her in the hospital. And I did. I stayed in the hospital by her side for 2 days. She was so terrified because it brought it all back. So the point that I'm trying to make here is that what we are really understanding now is adverse childhood events and how that changes our brain. This is not mental illness. Nobody is saying this is mental illness. It's not. It's what happens to a brain, a child's brain, presented with persistent trauma. That child becomes that brainstem has one job: to save that child's life. The way it's going to do that is by being very vigilant. Fool me once, shame on you. Fool me twice, shame on me. That's not quite the right way to, that's not quite the right way to look at this. But that brain knows if you've been hurt once, chances are you're going to be hurt again. That brain's going to be more hypervigilant. You're going to be in fight or flight. So therapeutically now, what do we do for this group? Now, I haven't said what happened to me. I grew up in a neighborhood with a kid who became a rapist and murderer, and I was one of his first victims in 4th grade. I didn't leave my home without fear for a decade. That's why I went down this pathway. I was in fight or flight from 4th grade to 35. And it was a class that I took at the age of 35 that taught me about this and taught me how to turn it off. Once I turned off the fight or flight, guess what? All of the other pain conditions went away. One of the signs of somebody who's in fight or flight is that the entire nervous system becomes very, very sensitive. We get sensitive skin, wicked sense of smell, really sensitive hearing. That's that brainstem. That's that brainstem looking for threat. So for patients who have multiple pain conditions, we're going to tackle this in a very, very different way because we know fundamentally it's not a problem with the bladder or the bowel or whatever. It's a problem with the central nervous system. And we're going to be doing techniques to bring that brain out of fight or flight. We're going to be doing mind-body medicine techniques. We're going to be doing EMDR therapy, trauma therapy, things like that to just try to prove to your brain you're safe, because it's remarkable that 30, 40 years later, that adult's brain is still behaving as if they're still at home with their violent dad, even though dad is dead. Our goal is to train the brain back into safety. It's all about your perception of safety. When we make the brain feel safe again, we can get the brain out of fight or flight, and that will calm all that down. Fight or flight is like an amplifier for an electric guitar. It amplifies pain throughout the entire body. So when we bring it down, it stops amplifying it, and we can calm the entire central nervous system down. That's the biggest change now, really, in the last 5 years, is really understanding this widespread pain phenotype and identifying techniques that we can use to calm it all down, all with the constant message that this is not your fault. You have done nothing wrong. There is no shame. There is no blame to be had for anybody with widespread pain. Again, migraines, TMJ, fibro, IC, IBS, vulvodynia. They're all connected. They can be connected through the central nervous system. So when we get back to the genetics study, I've worked with several people who say, you know what, I'm just remembering these conversations I had many times. I've talked to patients who say, well, my sister has this and my brother has this and my other brother has this and we all struggle. Some have migraines, some have this, some have that. And in the end, it's all about the home they grew up in and how they were treated as children. There is a fabulous documentary that is called The Me You Cannot See. And it was a Oprah Prince Harry production like 4 years ago. I think it's on Apple Plus. Stunningly good, life-changing documentary for anybody who has gone through trauma, or if you have a family member who's gone through trauma. Because it really, and Prince Harry is a tiny part of it. It's not like it's all about Prince Harry. It's not. It's they take, like, children live in war zones, people in this, people in that. It's all about following and understanding the different ways that childhood trauma can affect somebody. And in the end, they brought in this roundtable of like the best experts in the world. And they were talking about it. Oprah was there and Prince Harry was there, and they were talking about how the brain responds to trauma. And Prince Harry, the one thing he said that I think was just so profound, he said, so this is not mental illness. You're not describing an illness, are you? And he said, what you're describing is injury. And they went, yeah, that's exactly what this is. This is a central nervous system injury. But thankfully, the central nervous system is very resilient. We know what to do. We can make it better. We can make it way, way better. I have a video on the anxiety class that I took that completely changed my life. I used to have panic attacks almost every week. And again, this was with a master's in psych, and I was a straight A student, and it didn't help. I still had panic. And I finally one day just said, oh my God, I'm missing something. And I signed up for a class. that changed my life. And it was taught by an orthopedic surgeon who also had anxiety disorder. And anyway, I have a whole video on that. And in fact, I just ordered, here, hold on a sec. Oh, here it is. Here it is. So the guy that changed my life, his name is Howard Liebgold. And this is the book, or one of his books, that I was just so incredibly helpful for me. Howard Liebgold. And so he's passed away. And this was a book that had been thrown away by the North Providence, Rhode Island Library, because I went online looking for, trying to find a fresh copy of his book because I couldn't find mine. And I'm so happy to have this. Yeah, I haven't had a single panic attack since I took this class. I've only come close once. And actually that was like 2 years ago when my dentist was, I changed dentist and she was being a bitch. The other book, recent book that I got is this one called Overcoming Your Childhood Trauma. Because I realize now that pretty much every damn decision I've made in my entire life has been based in part on the fear that I lived with constantly. And so I'm very, very invested now in wanting to stop that behavior. And I have stopped a good portion of it, probably 90% of it, but rewiring the survival mind. Our brain is wired to try to survive a crazy world right now. So how do we rewire it back into calm? Really hard when you got social media making you upset all the time. That's for sure. Anyway. All right. What have I missed? I know that I've got 20 people here listening to me. So I hope, Max, I hope that helps. How do you work with the nervous system to kick it out of fight or flight? With really good sensory input. You got to remember, fight or flight is being driven by sensory input. What do you see? What do you hear? What do you smell? What do you taste? And what do you touch? So when we prove to your brainstem through sensory input that you're perfectly safe, your brainstem turns it off. And so let's do, listen, we're near the end of this meeting. We've been going for 2.5 hours. I can talk forever. I'm happy to talk about anything. But let me walk you through the technique that I use every day I work with patients. It works every time. It will never not work, okay? We can turn your fight or flight off in 5 minutes. Easy peasy. Okay, there's just one rule. You cannot talk about IC at all in this discussion, okay? So let me give you this technique. Let's just do 2 deep breaths. Let's just go in for 3 and out for 5. Let's do it one more time. In for 3 and out for 5. Okay. I want you to pick something in your room or out the window that you enjoy looking at. Like I have a painting on the wall right here from a childhood friend of mine. And it's this beautiful hay, golden hay covered field here in Sonoma County with oak trees in the background. I want you to pick, so you could be looking at flowers, you could be looking at your cat sleeping, your dog, a family member. Just pick something that you like to look at. And let's just look at it for a couple of seconds. That's all, just a couple of seconds. Okay, deep breath in, deep breath out. Now we're going to do hearing. I want you to take a moment and listen. Can you hear anything? And it's okay if you can't, but can you hear a TV? Can you hear the wind? I'm going to stop talking. I want you to just listen. Are there any sounds in your environment? Okay, deep breath in, deep breath out. Now we're going to do the sense of smell. Can you smell anything right now? Good smell, bad smell. It could be bathroom smell. That's okay. Could be dinner cooking. Could be cinnamon rolls. Could be perfume. Could be your dog or your cat. Take a moment and just sniff. What can you smell? I got nothing here. I can't smell anything here. But that's okay. Deep breath in. Deep breath out. Okay, what flavors are in your mouth? You got any tastes in there? Or are you just snacking on something? And again, it's okay if there's no flavors in your mouth. But just take a moment. What do you taste? Anything. I can taste a little tiny bit of lemon. Okay, deep breath in. Deep breath out. Now I want you to take your hand and I want you to rub it up and down your thigh 10 times. Okay, we're doing the sense of touch. You are making your brain and lighten up right now like a thunderstorm, but it's good. There's nothing bad here. We're just making it work. Kind of soft. I'm wearing real soft denim, right? I've got some pockets in there. Can feel the texture. It's good. Nothing bad happening here. Feels good, right? Deep breath in. Deep breath out. Okay, now comes the fun part. But again, for this part, you cannot refer to IC at all. This is not about IC. If you could look at anything that would put an immediate smile on your face, what would that be? Would it be a beach? Would it be a waterfall? Would it be a kitten, a puppy running to you? Would it be a grandchild running to you? A child running to you? What would you just love to look at that you know as soon as you saw it, it's like, oh, that's so sweet. What would you just love to look at? Close your eyes and think about it. For me, I'm going to go with a beach in Hawaii that I've been to twice. I had family that lived in Hawaii called the Kahala Beach. Small little local beach. Tourists don't know about it. And it's like 50 feet of warm sand with beautiful waves coming in and pelicans flying over and seagulls flying over. The sun is warm and the sand is warm. So I want you to close your eyes and I want you to just imagine, what would you just love to look at? Just be there. A couple of seconds. Deep breath in. Deep breath out. Okay. What could you listen to? What could you hear that would put an immediate smile on your face? Would it be ocean waves? Would it be a child's laughter? Would it be your favorite music? For me, every single time, it's Kenny Loggins' Pooh song. Winnie the Pooh doesn't know what to do. Got a honey jar stuck on his nose. I'm sorry, that just makes me really happy. I just love that song. So let's close your eyes, and I want you to imagine listening to something that brings you joy. It could be a Christmas song. It could be a cat purring. Just close your eyes and just go there. Deep breath in. Deep breath out. Okay, now this is where aromatherapy really works. What could you smell that would put an immediate smile on your face? It's so interesting. The patients you talk to, nobody's ever got, people go, oh, I've never even thought about that. In fact, I did that with my dad. Very interesting, 100 years old. It's like, God, what's your favorite thing to smell? And I think his answer was beer. For me, it's baking cinnamon rolls or coconut. Anything coconut smelled, I love the smell of coconut. I love the smell of the old Sea and Ski suntan lotion. But I also like the smell of roses. So what can you smell and just, it smells so good. What would that be? You know how when you're driving out to the ocean, but you're not there yet, you're like a mile away, and you roll your windows down and you can smell the salt air, and it's like, oh, we're almost there. It's so good. Okay, close your eyes and do that. What's your favorite smell? Okay, deep breath in, deep breath out. Okay, now for this next one, it's not about icy or anything. We're just being on our brain. What could you put in your mouth and eat that would make you go, oh, this is perfect? Think about K-pop demon hunter ramyun. Thing when they're on the plane at the beginning of the movie and they're eating their ramyun and they're just going, oh, this is so good. What would you just love to eat? Just one bite, you put it in your mouth and it's like, oh my God, this is exactly what I needed right now. What would that be? Would it be a hot cinnamon roll? Would it be a hot cookie? Would it be a steak? Would it be, I had somebody who very clearly described this incredible chocolate cake. She just wanted one bite. And it was so good. What would you just love to eat? You put it in your mouth and go, babe, this is it. This is what I wanted. Think about that. So I'm going to go with the hot cinnamon roll because that's my happy place. Anything hot and gooey and cinnamony is my happy place. Okay, deep breath in and a deep breath out. Now, last but not least, what can you touch that would put an immediate smile on your face? Would it be a cat in your lap? Would it be your lover? Would it be warm sand at the beach? Fresh cotton sheets? When you put the sheets on your bed right after you take them out of the dryer, oh, come on. That first night on sheets is great. But what could you touch that would put an immediate smile on your face? Your dog, your cat? Close your eyes and just touch it. I can feel my cat, Sammy, right here. Okay, deep breath in, deep breath out. Okay, how do you feel? You feel better? That's how you get your brain out of fight or flight, is you give it good sensory input. And what's so cool is doing this with anybody who's anxious, especially children. Do you think you've got a child who doesn't want to go to school or something like that, or maybe came home crying from school because of whatever? Take them out in the back and just walk through this. Hey, honey, what would you just love to smell right now? What would that be? What would you love to taste right now? Like get their brain grounded in good sensory input, and that just calms everything down, guys. Everything. Now, the other part of anxiety disorder that's very frustrating is that when you have been a victim of trauma, as I have been, and as so many of us have been, our brain tries to protect us. So, when I finally said, all right, clearly I'm missing something, and I took Dr. Liebgold's class, like the first revelation, and of course I had a panic attack on the way to the class, but I went, because back then I had a lot of panic attacks. The first revelation happened in the first 5 minutes because, like, I always thought I was like a poster child for being dysfunctional. And I mean, I hid it from everybody, but on the inside, I was just being tortured by anxiety. And when I actually met other patients and we all introduced ourselves, what the very first lesson is, oh my God, we're entirely normal people who had something bad happen to us. Oh, that happened to you, and that happened to you, and that happened to me too. And that immediately took all the shame and blame I felt away. When I actually met other people who'd gone through childhood trauma, it's like, oh, okay. It really wasn't me. I'm a normal person who just got hurt. Okay. That was so important to my mental health. And then he said, how many of you say no to every invitation? We're all looking at each other. Oh, you too? You too? Oh, everybody had their hands raised. He's like, do you know what that is? Like, no. He goes, that's your brain trying to keep you safe. That's your brain. That's fight or flight, trying to keep you at home where you're safe at home. Now, of course, for patients who had trauma at home, their reaction is going to be the exact opposite. But the point is that our brain says, somebody says, hey, you want to? And your brain goes, no. Like, I literally said no to almost every invitation in my 20s. Literally. And I wanted to accept every single invitation. Before they were even done, my brain went and my mouth went, no, I'm sorry, I can't do that. And I'm like, why? I literally wanted to do everything, but my brain said no. And he explained, that's fight or flight. That's your brain trying to keep you at home because you're safe at home. And he said, the challenge with that is that you eventually catch on that that's kind of happening. So your brain gets very creative and you start to catastrophize. Hey, Jill, you want to go take a drive? No, we'll be in a terrible car accident. Hey, you want to go to the movies? No, I'll have a terrible time. I'll have to go to the bathroom all the time. Hey, you want to know it's something really bad's going to happen. That's called catastrophizing. And as he explained, every time you catastrophize, you go right back into fight or flight. So the second piece of this puzzle is to turn that off. So he said, how many of you are sensitive, like sensitive to chemicals? Everybody raised their hands. He goes, and how many of you are sensitive to medications? Like, you don't like to take them, you get side effects. Like, everybody in the class. Yeah, you too? Oh my God, we all did that. And he's like, well, you know what that is, don't you? I'm like, no. He goes, well, that's your central nervous system being really sensitive because you're in fight or flight. And he said, just as you're insensitive to chemicals on the outside, guess what? You're sensitive to chemicals on the inside. And right now, every single one of you sitting here is overdosing on adrenaline. You got so much adrenaline shooting through your body. That's what's making you crazy. That's what's driving the panic. That's what's making you afraid to do stuff, is that you're just swimming in adrenaline, because adrenaline is the chemical mediator of fight or flight. It's the adrenaline that raises your heart rate. It's the adrenaline that raises your blood pressure. It's the adrenaline that tightens your muscles. And every time you have a negative, scary thought, you have a jolt of adrenaline. So you're overdosing because you have like 100 thoughts a day, 200 scary thoughts a day. That's a hell of a lot of adrenaline. So the secret to controlling anxiety is we got to get rid of the damn adrenaline. That's the problem. And we're like, okay, how do we do that? He goes, easy, oxygen. Oxygen turns off adrenaline. Like, okay, how do we do that? He taught us a 3-step technique that I still use today. He said, whenever you have a negative thought, the very first thing you do is you just visualize a stop sign. Just stop. Don't want to hear it. Just stop it. And then you take a deep breath in for 3 and out for 3. And that oxygen renders the adrenaline from that negative thought chemically neutral. It is done. It is over. It will not build up in your bloodstream. So stop sign, deep breath. And then you have to remind yourself, it's just a thought. It's just your brain guarding. There's nothing real there. It's just a thought. It has absolutely no power. So what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow is going to be the best day of your life. It's just your brain guarding. It's just a thought. It's completely powerless. Stop sign, deep breath, minimize the thought. And he said, okay, we have one goal for the first week. Just one goal. All we want to do is bring down the adrenaline levels, the quantity of adrenaline. So I want you to go home and I want you to do this. Pay attention to your thoughts and do it. Just for a week. That's all I need. Just for a week. And the science made total sense. We're all like, okay, I'll absolutely do it. And of course, I had my first negative thought walking out of class. Oh my God, this is stupid. It'll never work. But I did it. Stop sign, deep breath, minimize the thought. And that first day, I was stunned. I had gotten so used to the negative thoughts and the fear that I couldn't believe all the negative thoughts I was having. And most of them were about me. Like, oh my God, Jill, you're pathetic. You're such an embarrassment. But every single time I did it, stop sign, deep breath, minimize the thought. I did it at least 100 times the first day. Second day, 50 times. And I'm not lying, guys. I'm speaking the truth. Third day, 20 times. It's going down because guess what? The adrenaline isn't building up because I'm nipping that adrenaline in the bud. 5 days later, I only had to do it once. And for the first time since 4th grade, I wasn't in fight or flight anymore. And it was a revelation. Oh my God. Wow, this is the way I'm supposed to feel, like calm, comforted. I hadn't felt that way in decades. So what the class ultimately taught me is that negative thought, it's all about, you got to nip those negative thoughts in a row. Now, I will tell you right now, every day I have one, and it's always about an earthquake. Do not ask me why. I have no understanding why every day, at least once, I ask myself, is the earthquake going to hit today? Okay. But if I have 2 in a row, stop sign, deep breath, minimize the thought, man, I am not letting that adrenaline build up. And if the rare occasions that I have 3 in a row, I do it 2 or 3 times because I know the enemy is adrenaline and I'm going to do everything I can to keep the adrenaline down. So that's the second piece of this anxiety management puzzle. So number 1, we prove to our brain that we're safe with sensory input, and we just have to learn how to nip these negative thoughts in the bud once and for all. I mean, I got so good, I would have 1 negative thought a week. I mean, and guys, listen, I'm very careful about my life. I mean, you can see I've got things here that make me happy. The windows are open. I don't sit behind closed doors in a dark room. I've got windows open. I've got things that inspire me everywhere. I've got colors everywhere. I really take responsibility for my mental health every day. And I purposely try to live in a happy environment. But again, it's challenging right now when we live in a world where people are making money by keeping us angry. And so I would just encourage you to just step the hell away. Like read a book, turn on a movie, just get out, call a friend, talk on the phone. Every Sunday after I do these meetings, I talk to my best friend for an hour, sometimes two. So that's the widespread pain phenotype. All right. Well, so we've been on for 3 hours now. I think this has been good. I'm really glad we got YouTube working again. So my YouTube friends, we finally figured it out. It was wires that had been crossed, got fixed this morning. So we got great upload speed now. And so now our YouTube stream should be good. Our Facebook stream should be good. I was going to stream on Instagram too, but I was going to do that through my phone, but I couldn't set it up in a timely way. So my goal here is to be back next week. Just a reminder, we are having a 10% off in the IC Network store. Just use IC Awareness as your promo code. You will get 10% off. That will be for another 2 days, and then that will be done. IC Awareness Month ends in 2 days. On our last day, we always want to recognize and acknowledge all of those who helped us tremendously who are now gone. We want to say thank you for all those wonderful doctors and researchers who helped, like Jerome Weiss, who passed away this year. My friend Diane, who helped me start my first online support group. I lost her about 15 years ago. Donna, who ran the IC Network Forum, helped tens of thousands of patients. So if you can, take a moment and think with gratitude for all of those ICers that we've lost and all those people who tried to help, because we wouldn't be here today without their support. And I hope that you now will act to help any others that you might meet. If you can, please send them over to the IC Network website. If you see somebody who's struggling and they just need somebody to talk to, please by all means feel free to talk to them on your own. But if they're suicidal, make sure you refer them to a therapist, because you're not a therapist. And you can always refer patients to me. I work with patients every day. I love working with patients. And all they have to do is call 800-928-7496. The phone number is up at the top of the IC Network website. So anyway, Brandon, you're welcome. Brandon says, I really appreciate the inspiration. You're very, very welcome. And Brandon, you got to introduce yourself to John. Listen, there are a lot of guys out there. There are a lot of guys out there right now. Y'all are just very, very quiet, because there's this perception that this is a female disease, and it's not. It's a pelvic injury, and I think the injuries affect far more men than women, to be quite honest. But anyway, all right, so last call for questions. Otherwise, get your flannel out, my friend. Take some hay rides. It's time to go get your pumpkins and your sweaters. And hey, if you can, have a bonfire and heat up a marshmallow, burn it a little bit. Listen, the taste of a burnt marshmallow is actually pretty good, as long as it's not black. Just that little tiny bit of char on a marshmallow is good. I just wish I could do the chocolate. Darn it. I just can't do anything with caffeine, and I can't do anything with fat yet. Although I got to try the fat again. Laura said, Jill called me. So grateful. I was low that day. Always happy. Always happy to talk to patients. If you ever need a pep talk, I'm your girl. All right, my friends. Well, I think we are done. Yep, we are done. So I'm going to say, can levator be cured? Well, honey, you don't cure a muscle, you heal a muscle. Yes, it can be cured. It can be healed, right? But it's going to take a physical therapist. You need to work with a physiatrist or an orthopedic surgeon, try to understand why your levator ani is under stress. Sometimes it's due to a broken tailbone out of position. Sometimes it's due to an SI joint. So, it's not just a muscle. We have to ask, why is the muscle tight in the first place? And that often relates to a bone. And in many cases, it's how your foot hits the ground. If you got an ankle that's rolling in, man, that's going to mess up your pelvic floor, my friend. And that's where this book is so awesome. Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Wonderful, wonderful book. All right. So again, you can buy any of the supplements, anything like that. Everything's 10% off on our website, icawareness.org. If you have trouble, just call tomorrow and I'll give you the discount tomorrow, or my staff will give you the discount tomorrow. All right. We only do 2 sales a year. So you're getting the fall sale. All right. All right, everybody. I will talk to you later. I'm going to say goodbye to YouTube. I'm so glad it worked on YouTube. Yes.